Okay. Good morning. I'd like to call this hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Wednesday, March 4th, 2026. The time is 9:31. Today we will discuss the FY25 performance of the DC Health Benefit Exchange Authority, also known as HBX or DC Health Link. This is a hybrid hearing with witnesses testifying both in person here at the John A. Wilson Building and virtually via the Zoom platform. The Health Benefit Exchange Authority is a quasi-governmental agency of the District of Columbia charged with implementing and operating the district's health benefit exchange. HBX operates DC HealthLink, an online marketplace for district residents and small businesses to compare private health insurance plans, learn if they're eligible for tax credits or subsidies to purchase private insurance or qualify for Medicaid, or enroll in a health plan that best meets their family's needs. HBX enables individuals and small businesses and their employees to find affordable and easy to understand health insurance. Before we begin, I want to commend the Health Benefit Exchange for the tremendous amount of work that everyone at the agency did last year in standing up the Healthy DC plan. This was a very large feat, and you all were extremely successful in a relatively smooth transition for such a quick turnaround. The committee did send written pre-hearing questions to HBX, and we'll reference those throughout the hearing today. If anyone would like to see those materials, they're available on the council's website, dccouncil.gov/hearings. I don't see any of my colleagues, but certainly we'll welcome them if we join them. So we're going to turn to public witnesses. Before I get started, I want to review the public witness testimony guidelines. Everyone will have 3 minutes. I'll give you a nudge once your time has expired. If you're testifying here in the room, there are multiple clocks. If you're testifying online, if you change your view to gallery view, you'll be able to see a clock there as well. For anyone who is not able to attend or speak at today's hearing, we'll certainly accept written testimony until March 18th at 5 p.m., and you may submit those online as well. All right, so I'm going to call the first panel of witnesses, Elizabeth Davis from DC Hospital Association, Ann Gunderson from DC Fiscal Policy Institute, Jacob Spidell, oh, there he is, and Kate Sugarman. Good morning, everyone.
Good morning.
All right. Ms. Davis, when you're ready.
Good morning, Chairperson Henderson. My name is Elizabeth Davis, and I am the Senior Director of Government Relations of the District of Columbia Hospital Association. Thank you for the opportunity to provide testimony at the DC Health Benefit Exchange Authority's FY25 Performance Oversight hearing. DCHA is a unifying force advancing hospitals and health systems in the District of Columbia. We are committed to promoting policies and initiatives that strengthen our system of care, preserve access, eliminate disparities, and promote better health outcomes for patients in our community. Our driving vision is to achieve an efficient and effective healthcare delivery system that supports a healthy, equitable, and vibrant community. On behalf of DCHA and our members, I want to express our sincere appreciation to Mila Kaufman for her leadership throughout the transition to Healthy DC. As you know, nearly 16,000 Medicaid beneficiaries transitioned into Healthy DC on January 1st, 2026. This was a significant and complex undertaking, and her team's commitment to continuity of coverage, affordability, and thoughtful stakeholder engagement made a meaningful difference for patients and hospitals alike. We appreciated HBX's efforts to engage hospitals at the beginning of the transition this summer. This early engagement helped our members get a better understanding of the accelerated timeline and process. I am pleased to report that all of our members contract with the district's Healthy DC plans, which has led to no decrease in access to care for patients. The one area that we will continue to work with the DC HBX team going forward is on rate setting. Now that these 16,000 individuals are no longer included in the Medicaid population, their cost of care will also not be included in rate setting. This is a potential problem for providers if the cost of caring for this population becomes more expensive than the Medicaid beneficiaries. Under this scenario, this would mean provider rates would not be sufficient to cover the cost of care at the Medicaid targets as anticipated. During the transition period, we partner with HBX through their advisory council to support coordinated outreach, education, and enrollment activities of Healthy DC. We continue to work with HBX to increase hospital staff and patient education about the new insurance cards. While we recognize that there was some confusion earlier this year, our hospitals are working with patients to help them understand their new coverage. We remain committed to working with HBX as Healthy DC moves from implementation to ongoing operation. Thank you for allowing me to testify, and I'm happy to answer any questions you may have.
Thank you. Ann?
Chairperson Henderson, thank you for the opportunity to testify. My name is Ann Gunderson, and I'm a senior policy analyst at DCFPI and a member of Under 3 DC. My testimony focuses on the progress the DC Health Benefits Exchange has made on healthcare for childcare, which is expanding its reach across DC and in wards east of the river. Health insurance is a critical component of compensation for early educators. Healthcare for childcare makes free or low-cost healthcare coverage available to childcare workers whose employers purchase coverage through the Health Benefits Exchange. To date, more than 3,300 childcare employees and their families have benefited from healthcare for childcare, many of whom are receiving employment-based benefits for the first time. Many educators have testified before the council about how life-changing this program has been for them, and every dollar DC invests in healthcare for childcare nets over $1 in premium value, making it a beneficial program for the entire district. The exchange instituted a wait list for new childcare facilities enrollment and healthcare for childcare coverage on January 1st, 2025, due to insufficient funding. There are no facilities currently on the waiting list, but there are 53 facilities who are eligible for coverage, but not currently enrolled in healthcare for childcare. The program covers 350 more individuals today than it did 1 year ago, reaching 2,317 people. Over the past year, the exchange has also made progress in expanding coverage in wards 7 and 8, which had the smallest percentage of facilities enrolled in healthcare for childcare group coverage of all wards this time last year. The number of people covered by facilities located in Ward 7 nearly doubled from 57 people to 104, and the number of people covered in Ward 8 increased from 219 to 289. Ward 7 continues to have the smallest percentage of eligible facilities enrolled, and the continuation of a waitlist for healthcare for childcare means delaying progress on expanding coverage in Ward 7 and across the district. Higher pay and affordable healthcare works hand in hand to fairly compensate early educators, and the healthcare program helps workers avoid costly benefit cliffs once their pay pushes them above income eligibility for Medicaid. As the federal and local healthcare safety net shrinks rapidly, protecting healthcare for childcare will be extremely important for protecting the early education workforce's economic security and health. For example, federal changes to healthcare policy have created restrictions on who is eligible for coverage and made it more expensive to deliver coverage, including in the marketplace. If lawmakers were to eliminate healthcare for childcare in the budget, many educators receiving high pay under Pay Equity Fund would not qualify for Medicaid. Some may not qualify for the Healthy DC plan, and others could be priced out of the marketplace given the loss of the enhanced premium tax credits. The limited budget for healthcare for childcare and constant threats of defunding the Pay Equity Fund are now stymieing progress towards the ultimate goal of early educators having access to healthcare when they choose to work in a DC childcare facility. We look forward to continuing to work with the Health Benefits Exchange to ensure that they have the resources needed to continue this important work. Thank you.
Thank you. Jacob?
Good morning, Chairperson Henderson. I am Jacob Spidel, a staff attorney in the Public Benefits Unit at Legal Aid DC. This testimony focuses on our comments and recommendations about administration of the new Healthy DC program. First, we encourage HBX and DHS to continue working with individuals who may have been mistakenly lost Medicaid coverage or been denied Healthy DC coverage during the transition. The creation of Healthy DC was a large undertaking, and we appreciate the efforts of the Health Benefit Exchange, DHCF, and DHS to make the transition as smooth as possible. There will be mistaken changes or terminations during any transition of this magnitude. At Legal Aid DC, we were contacted by several individuals with coverage issues. We have raised individual issues of concern with HBX, and HBX worked with us to correct their information, and coverage was restored. Continued cooperation and attention will be critical in the months to come. Some beneficiaries may not yet realize the extent of changes to their coverage. This is because most affected beneficiaries were seamlessly transitioned from Medicaid to Healthy DC and kept their same MCO. So beneficiaries may not understand the changes until they try to access a service that's no longer covered, or they try to see a provider that accepted Medicaid but does not accept Healthy DC. So as this transition continues, DHS and HBX should continue to be responsive to individual cases to correct mistaken losses or changes in coverage. Second, DC should expand covered services to include dental and vision benefits. As we've testified before, the lack of dental coverage in particular is devastating to people who've been transitioned from Medicaid to Health ADC, which does not cover any dental benefits beyond medical emergencies. DHCF estimated that approximately 5,800 people in the group transition from Medicaid to Health ADC had used dental services through Medicaid in the previous year. Excluding comprehensive dental coverage will ultimately lead to more health emergencies as people go without preventive care. Since the transition, Legal Aid DC has encountered multiple clients who've been having issues accessing dental care. And the estimated cost for providing dental coverage to Health DC population is a tiny fraction of the district's annual budget, but would have an outsized positive impact on those individuals moving from Medicaid to Health DC. Third, Health DC should utilize a continuous enrollment policy beyond the first year of operation. Health DC is using continuous enrollment during the first year of operation, allowing individuals to apply for and begin receiving coverage at any time of the year. After the first year, Health DC plans to switch from continuous enrollment to open and special enrollment. Continuous enrollment is an administratively simpler process and is especially helpful for people whose income fluctuates close to the income limits over the course of the year. In conclusion, the council must protect healthcare access for district residents, and we encourage them to do so as they set the budget for the next year.
Thank you. Dr. Sugarman.
Hi,
Oh,
good morning.
just got to turn your mic on. Push the button. There you go.
Okay. Good morning, Chairperson Henderson, and thank you for hosting us this morning. I'm Dr. Kate Sugarman. I've been a family doctor in Ward 1 in DC since 2003, and I'm currently employed at Unity Healthcare. Most of my patients are low income, and they depend on the DC government for their healthcare. So I'm speaking this morning to make sure that the transition is as smooth as possible and that no critical benefits will be taken away from our patients in the transition. Dental care, as mentioned, is crucial to our patients' well-being. Toothaches, dental infections, cavities, the need for root canal, these are all critical, and it's the main reason why people lose days from work because of dental problems. So dental care is nothing that is elective or cosmetic. This is critical to people's lives, and people do die from dental infections. And as doctors, we very much stress preventive care. We hate for people to end up in the emergency room with a horribly infected tooth and an abscess when if they had had dental coverage, they would be able to receive this as a routine part of their health care. The same for vision. We want our patients to be able to see, and if people are living paycheck to paycheck at best, people need to be able to see in order to lead independent lives, in order to work, take care of themselves, and take care of their families. And these transitions I've already seen with certain patients, the transition can be rocky. And if people have critically dangerous medical conditions, diabetes, heart disease, cancer, liver disease, kidney failure, even a break in care can be life-threatening. So, when people go to the pharmacy and they're told, no, your insulin is not covered, that's an emergency, and this is happening again and again and again, that people need to be able to get their medicines, get their specialty care without any interruption. It has to be seamless. The same is true even for broken bones. People need for that to be treated. We don't want these patients to end up in the emergency room, as will happen when people have reductions or interruptions in their care, because care in the emergency room is not appropriate for outpatient conditions, and then the emergency rooms get clogged up for the patients who do need it, the patients with heart attacks, car accidents, things like that. So I'm urging that there be no reduction in healthcare. If there is a transition, that everything be covered, and in the mayor's future plan for 2029 to eliminate the participation in the ACA, that is completely unacceptable. We want our patients to be healthy and to thrive. Thank you.
Thank you. Thank you so much to this panel of witnesses for both your advocacy, but also for your feedback and engagement on these various issues. Dr. Sugarman and Jacob, so we've been advocating for the coverage to include dental and vision maybe a lot of people don't realize is that when we were planning out the transition to Healthy DC, there was already a trigger that was built in for dental and vision coverage if the federal government had extended the federal tax credits that were available under the ACA. It is March, and to date, Congress still has not taken any action on that front. And so now we're sort of left in this limbo of what do we do? Because I agree with you, dental care, vision care, even though many, many moons ago, Congress kind of made the decision that dental and vision is somehow separate from the rest of the healthcare of your body. I think we all know that it's all interacted. It's right. Someone can, we had cases even in our region of people who have died from untreated dental issues. So it is all connected, and it's something that we're continuing to try to work on with the executive to go ahead and extend this coverage, because I think to have had it under Medicaid and then to switch and not have it under Healthy DC is certainly a shift. And purchasing separate vision and dental insurance is not it's not an affordable thing for most. So thank you for being here. And thank you for being here and your continued advocacy for healthcare for childcare. It's such a great program in terms of, right, I think at this point, over 2,300 folks have been able to have access to health insurance that didn't otherwise have it. And so getting rid of this program, that's 2,300 people who are taking care of district kids who will no longer have access to take care of their own kids and families if some health insurance situation arises there. So thank you for being here. Ms. Davis, I wanted to ask a follow-up question. So your testimony was around rate setting, or a portion of it. And that is the concern, if just to clarify, is the concern that the population of Healthy DC won't be included in the rate setting on the private insurance side of things?
Thank you for that question. To clarify, we are just looking at how much it will cost to take care of that population and seeing if there are any changes in that coverage. So what we have been doing is, now that we're almost a quarter in, beginning to like survey our members and seeing if there has been any changes in that coverage. So continuing to look at if the cost of care with the contracting, as I noted, all of our members are contracted with the Healthy DC plans.
Yeah.
But looking to see if the cost of care, if there is a change in the population.
Okay. All right. I think that would be helpful to look at, but also just kind of in general, there's so many things that have happened at once that I think it's probably hard to sort of isolate what is responsible for what, right? The expiring tax credits it did impact the number of individuals who chose to hold on to their private health insurance. Is that showing up in the hospital room now or in the emergency room now? Are you seeing increased volume? The same could be said around the reduction in alliance coverage, or individuals who, due to immigration enforcement or otherwise, have decided not to re-enroll, to drop off coverage, right, because of public charge, et cetera. Yeah. When is the end of the quarter coming up?
It would be the end of March, I believe, since the beginning of this program, but with the alliance changes, as you noted, that started back in October 1. So we'll have some more data to be able to see, like you noted, if there have been any changes in, the emergency Medicaid and those claims. So we're beginning to survey our members and hope to have some information as we get ready for budget oversight.
Okay, sounds good. All right, well, I don't have any further questions. Please make sure you provide your written testimony for the record. Thank you so much for being here. Okay, we're gonna go to the next panel of witnesses. Elizabeth Falcon, Anna Jimenez. Is there Anna? Okay. Chioma. Let's see, Chioma. Pat says she's not coming. Susan Lee Locker. Oh, Susan's here. Jimmy Williams. And Louis Bum base. Is there Louis? Oh, sure. If she gets here in time. All right. Are you Daniela?
Yes.
Okay.
Thank you.
All right, Elizabeth, when you're ready.
Good morning, Chairperson Henderson, and thank you for the opportunity to testify. My name is Elizabeth Falcon. I'm the Executive Director of DC Jobs with Justice. Since the spring, we've acted as the anchor organization for the Keep DC Healthy campaign, joined by 25 other organizations. Keep DC Healthy is a coalition of health providers, grassroots organizations, policy organizations, and advocates who believe that healthcare is a human right and embraces DC's long history of nearly universal access to health insurance. We oppose the elimination of the DC Healthcare Alliance program and the plan to shift thousands of Medicaid recipients to a new health plan with limited or no access to dental, vision, and long-term care coverage. We call on the council to ensure these programs restore full coverage, meaning income eligibility, removal of age caps, and return to full services that existed before October 1st, 2025. Maintain DC's role as a leader in ensuring that Black, Brown, and all low-income residents get the health care they need. We were surprised and confused to learn that the mayor was creating a basic health plan, now called Healthy DC, in the FY26 budget. The transition led to the loss of dental and vision coverage for more than 1,000 DC patients. Since then, we've offered a solution to this problem for FY26. We supported the inclusion of a $21 million on the contingency revenue list to restore coverage for Alliance patients. Now that we're halfway through the fiscal year and with declining enrollment in the Alliance, DC has the funds to restore Alliance services and dental and vision coverage for BHP and Healthy DC patients. We've been disappointed that the agency is operating with its hands tied as the mayor refuses to release funds identified in the Budget Support Act to restore any healthcare cuts, including dental and vision coverage to basic health plan patients. As we've shared with the council members, we fully support utilizing these funds to restore vision and dental care to BHP patients. We caution, however, against equating restoration of dental and vision for BHP patients and Alliance patients as equitable. Participants in BHP have higher incomes than Alliance patients, and Alliance patients at the income level have been removed from the program since October 1 and are not eligible for Healthy DC or Medicaid. Additionally, all Alliance members at every income level have lost at least 9 additional services, including dental and vision, which are critical to their health. DC can and must restore the same level of care and coverage to Healthy DC patients as they were able to access previous to October 1, 2026. Additionally, the Department of Behavioral Health is no longer providing locally financed behavioral health services to patients who were previously on the Alliance, and it appears they have also eliminated that support for Healthy DC patients. This plan was not articulated during the budget process and has not been effectively communicated to providers. Ultimately, the most important thing is that patients who are being left without mental and behavioral health supports. We call on the district to clearly identify how the move to BHP affects all aspects of individuals' health and how behavioral health treatment plans are being addressed for BHP members. Thank you.
Thank you. Susan.
Thank you, Chairperson Henderson. I'm a PA and I've been working in DC in primary care with a focus on HIV care for over 40 years. I've seen it all, including the bad old days before we had the DC Alliance. DC Alliance has made it possible for people with HIV in particular, but people with all sorts of chronic conditions in DC to receive better health care than almost anyone else in the country. When primary care and continuity of care is interrupted, we have unexpected results. For example, the main cost to Metro for the paratransit system is actually renal care, dialysis for people with diabetes that was uncontrolled or hypertension that was uncontrolled. So these costs come out. Same way with dental care. When you lose your dental care, it increases heart disease. And all of these things and the stresses of these things make all of our patients less healthy through weathering effects of the chronic stress that they face every day of their lives, trying to fight with systems that keep changing and make it difficult for them to address their daily needs. I've had patients whose loss of care have led to them stopping their HIV medications, which leads to the rates of infection of others in their environment to increase. The rates of DC of HIV have previously been higher than the country of Uganda in the bad old days. They've gotten much better over the years, but they remain among the highest in the nation. We've been really good at reducing new infections by supporting primary prevention for people and secondary prevention for people with HIV through care. But if we lose coverage, even for a short time, sometimes the drugs no longer work. And so we have to change to more expensive and more difficult regimens that people then cannot follow. So I don't have specifics, I don't have numbers, but I'll just tell you from the patients I've worked with, anything we can do to support their ongoing continuity of care, anything we can do to support dental care, vision care, because yes, they are a part of the whole body, is going to be important. And I'll stop there and open to questions.
Thank you. Mr. Williams?
Good morning, Chairperson Henderson. How are you? My name is Jimmy Williams, and I'm a proud Ward 7 resident, an advisory neighborhood commissioner, and president and CEO of the Washington Literacy Center. I am also one of the nonprofit leaders that rely on DC HealthLink to provide coverage for ourselves and for our staff. The Washington Literacy Center was founded 63 years ago. Our organization provides adult literacy, workforce development, programs to help district residents build reading, math, digital literacy skills to secure employment, especially in today's economy. Reliable and affordable health insurance is essential for those who dedicate our careers to serving the community. Without the Affordable Care Act and DC HealthLink, the health insurance options available to my organization and many nonprofits like ours would be significantly more expensive and in some cases completely out of reach. Programs like DC HealthLink are especially important for nonprofit organizations that serve communities where economic and health disparities remain very significant. I would like to briefly share how DC HealthLink team has supported us during the very difficult period. Last year, our organization, as you may know, experienced a sudden and unexpected government funding loss for our adult education programs, one of our primary programs. As a result, we faced a temporary disruption in our health insurance coverage. During that challenging time, we worked very closely with DC HealthLink team. They helped us identify a plan that met both our needs and our budget under a revised benefit structure, which was very important. My leadership team and I are deeply grateful for the responsiveness and professionalism that DC HealthLink staff as we navigated through that very difficult period. I thank Vernon Wembley on my staff, but I would also like to recognize Kelly Scott and Candace Holloway, whose engagement with our organization reflected the very best of public service. They listened to us carefully. They didn't always tell us what we wanted to hear, but they helped us identify very practical and realistic solutions. Nonprofit organizations like mine operate on a very tight budget. Many of us compete with larger employees and for talented staff. And rising health care costs have made it increasingly difficult for small employees like mine. As chief executive of an organization that serves many vulnerable residents, it's important that we continue to be able to care for the well-being. The work of DC Health Link is not easy, but their commitment is real, and the positive impact on our organization and therefore DC is real. I thank you for the opportunity to share this experience, and I would be happy to answer any questions. Thank you for your time.
Thank you. Daniela.
Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to address the council today. I am Daniela Gonzalez Rios, the Health Justice Coordinator at Advocates for Justice and Education. Each year, we assist hundreds of families through direct services, training, and advocacy in navigating districts' public education and healthcare systems. At AJE, we have a parent ambassador program that promotes leadership development for veteran family leaders who have firsthand experience navigating DC systems of care for children and youth with disabilities and special healthcare needs. One of our parent ambassadors said, "I'm wondering how they're going to reconcile not providing dental care when poor dental hygiene leads to some more expensive chronic ailments like heart disease. It impacts a lot of stuff in the body if you're not able to access that." We hear concerns like this on a daily basis. The district's Healthy DC plan emerged as a direct effect of lowering Medicaid eligibility thresholds from 200% below the FPL to 138% below the FPL, resulting in nearly 25,000 people losing Medicaid coverage. Of those, approximately 15,000 were expected to qualify for the basic health plan. However, the plan does not include comprehensive dental or vision benefits. It doesn't provide housing support, case management, or community-based services, or cover assistance with daily living, nursing home care, and home health aides. Black and brown low-income families are at the greatest risk. Healthcare does not exist in isolation. It is deeply connected to the housing crisis, food rising costs, childcare costs, escalating transportation expenses, or increasing utility burdens. When families face barriers to basic needs, not only does it add to the ongoing stress of making ends meet, but also creates a ripple effect on children's and adults' developmental outcomes, educational attainment, and long-term economic mobility. These effects will extend across generations. When residents stop seeking primary care, stop getting tested, and stop managing chronic conditions early, hospitals and emergency rooms will see them later, sicker, in crisis, and will be far more costly to the system. What about the near elderly who do not yet qualify for Medicare and who may not have children or family to support them? If this crisis continues, the outcome is predictable: more untreated illnesses, more debt and fear within families, and more preventable deaths. The question is not whether harm will occur, but how much harm is acceptable before action is taken. DC families deserve to have adequate, responsive healthcare, stable housing, access to nutritious food, and strong community resources. We urge the council to fully restore coverage by using available contingency funds, including restoring dental and vision care. We also urge the council to prioritize clear, consistent, responsive communication and education and meaningful support to help families navigate these changes. Thank you for your time and consideration, and I welcome any questions you may have.
Thank you. Thank you so much to this panel of witnesses. And I think some of you covered some of the very similar things that we discussed on the prior panel. Susan, your testimony about the work that you have been doing with HIV patients sort of rang a bell for us, because yesterday we actually, the council did final passage of the PrEP DC bill to make PrEP and PEP available with no cost sharing, which will be huge. And to your point around the importance of continuity of care, just for folks, right? Anytime someone has to take a pill or a shot every day, there's a high likelihood that you're gonna miss a day, or you're not going to take it in the same hour, or like you could set alarms all day long. And I see the women who are sort of shaking their head like, yes, like it is hard to do it every single day. But when you have an opportunity to have a medication where you only have to take the shot once every 6 months, all right, this is much better in terms of coverage, and also much better in terms of individuals being able to manage and do those things. So that just sort of brought to mind. But I think we are all aligned in sort of the desires around these things. The council had a meeting with the mayor last month. I don't know, the snow, the weather, it all like, it's March, wow. And that's a surprise too. But there was this conversation about the contingency list. We've had I have had follow-up conversations with both the mayor as well as the deputy mayor, specifically about this issue of dental and vision. And I don't know, I foresee a problem. I think we all foresee a problem. And it is not a terribly expensive solution. That is the part that is like, it's not terribly expensive if we think about it, to be able to provide this level of preventative care coverage. But I don't have any further questions for you all at this time. I'm sure I will see many of you again in the next month and a half or so. But thank you so much for being here. Thank you. Okay. All right. So Chioma, Daniela took your spot, but you're here now, so welcome. Gustavo Alua. Okay. Roberto Carlos Salas. Okay. Okay. And let me just go back really quickly. Louis Bumbase. Okay. All right. Chioma, come on. So I have 2 seats. If there's someone here who thought that they were supposed to testify in person, but I didn't call your name, tell me. Okay, what's your name? Oh, yeah, okay. All right, I see you. They have you on virtual, but yep. Okay, anybody else? I have 1 more seat. All right. Anybody else want to testify in person? Now's time. Okay, all right. Why don't we start with Chioma?
Okay. Good morning, Chairperson Christina Henderson and team. My name is Chioma Rue, and I serve as the Health Justice Project Director at Advocates for Justice in Education. As my colleague has noted, we work closely with a neurodiverse population of DC families, many of whom rely on DC Medicaid, the Alliance Program, and the DC Health Benefit Exchange to maintain access to care. AJE is deeply concerned about the rumored proposal to phase out so-called childless adults from Medicaid by 2029. This designation does not reflect the lived realities of DC families. Many fathers, non-custodial parents, kinship caregivers, and caregivers of adult children with disabilities may not appear in eligibility systems as primary caregivers, yet they are financially and functionally responsible for supporting children and youth with complex needs. Eliminating coverage for these adults risks destabilizing entire caregiving ecosystems, undermining family-based care. We are also concerned about the reduced access to primary and preventative care. Primary care is a core determinant of long-term health outcomes. When coverage is reduced, we see predictable shifts towards delayed treatments and increased emergency room utilization. The FQHCs, which already operate on thin margins, are projected to experience 5 to 10% financial losses under eligibility reductions. I have a question for you, Chairperson Henderson. What is the district's mitigation plan to preserve the quality of care of these FQHCs serving our most vulnerable families? One of our parent ambassadors has shared, to afford health care, you have to ask, am I going to get insurance for my family, or are we going to go without eating? That's an extremely concerning choice to make as a mother who loves her community. Additionally, AJE is concerned about the lack of clarity of immigrant adults who have lost coverage. What is the district's concrete plan for this population? What pathways exist for home and community-based services for children and youth with complex medical needs who rely on Medicaid or Alliance? What is the plan for the transition-aged youth who age out of alliance, yet have pre-existing conditions requiring continued care. Finally, families of children with disabilities already experience higher out-of-pocket costs than families of typically developing children, with national projections showing significant premium increases in the ACA marketplace. Even with subsidies under the Inflation Reduction Act, affordability remains fragile. What is the district's strategy to proactively educate families about subsidy eligibility and enrollment options? And will the council consider additional local financial relief mechanisms for families of children with disabilities navigating the systems of care, including the exchange? I have these questions that I hope I get answers. Thank you for your leadership, and I hope you can address some of these pertinent questions.
Thank you. Roberto? Oh, if you could just turn your mic on.
Morning.
Morning.
I want to thank the Oversight panel for giving me this opportunity to express my thoughts and concerns about the DC Health Benefit Exchange. I have called Washington, D.C. my home for more than 33 years. During that time, I have witnessed how the city has evolved and transformed neighborhoods, how long-time residents have sometimes been displaced, how the real estate boom has changed the demographics of our communities. Change can be positive when we place human values at the center of our decisions. People are the most important assets of any society, and every person deserves access to basic human services. For me, healthcare is one of the most essentials. A few years ago, I appeared before this body to express my concern when my health insurance premium increased from a few $100s a month to more than $1,000. It was unsustainable. Fortunately, I was able to maintain my coverage because the advanced premium tax credits, APTC, lowered my monthly costs to a level I could afford based on my income. Nevertheless, even with the same plan I had last year, my premium doubled this year. Without the assistance of the advanced premium tax credit, having health insurance will simply not be an option for me and my family. This benefit helps people like me. I'm a minority small business owner who has worked hard to provide for my family. My wife and I have raised 2 children who are DC natives and first-generation descendants of immigrants. Reaching our goals has not been easy, and one of the priorities has always been maintaining health insurance for our family. Health is invaluable, and without health, everything else becomes secondary. Recently, a well-known actor around my age passed away unexpectedly. It made me reflect on how anyone can suddenly face a serious health situation. In a country where healthcare costs are extremely high, an unseen person can lose everything they have worked for, including assets meant for their children's future. For this reason, I encourage this panel to continue protecting programs like a DC Health Benefit Exchange that helps residents maintain coverage. At the same time, I want to highlight the lack of transparency in healthcare billing. Patients often cannot clearly understand what a service costs, how much is charged to insurance, and how much is billed to them. Healthcare pricing should be as transparent as the price of an item in a store. Greater transparency and oversight are necessary if we want to further a more accessible healthcare system. In conclusion, the DC Health Benefit Exchange provides an important lifeline for residents like me. I hope this program continue to be strengthened so more people in our community can maintain access to affordable healthcare. Thank you for your time and consideration.
Thank you. Christopher?
Thank you, Chairperson Henderson, especially for mentioning opening remarks, small businesses, because it will be the focus of my testimony. My name is Christopher Honey. Like Mr. Williams before, I am a proud resident of Ward 7, even prouder parent of a DC public school student. And I'm here because I'm just asking you and the entire council, whatever they can, to keep healthcare premiums down. I am hoping that some of you have seen some brightly colored onesies with animals on them, or the ones that have the DC flag but have animal heads instead of the stars. Those are a little fishy. Those are not me, that is my wife. She is the mastermind of that business. And here in DC, in Ward 7, the silk screening, the sewing, all the work happens here. We're very proud of it. And well, we have a family. We need affordable health care. And I know the Wall Street Journal assures me that taxes and regulation are the real impediment to our business, but I am far more afraid of my health insurance premiums, outstripping my mortgage. You want a business-friendly environment, we need to have affordable health care. Nothing is more toxic than not being able to take our child to the doctor, or like I said, having premiums that are suddenly shooting up above the cost of my mortgage. and our customers as well. You know, we serve, middle class and working people in DC, and if their premiums go up, they're going to start shopping at a Walmart in the suburbs instead of supporting local businesses like us. And look, that small businesses are vital to the economy. They keep people working and shopping locally. When small businesses suffer, the economy suffers, and our general quality of life, what makes our neighborhoods vibrant. So DC Health Link is just such a wonderful opportunity for us to take the plunge. We can't, leave traditional employment, start a small business, a huge plunge. And if we're shopping on the old-fashioned open market, it's just not possible. This is really the key to people like us continuing to take that risk and start small businesses here in DC. So please support us and support others with the same dream. Thank you.
Thank you. We have one person who just arrived, Anna Jimenez. Did you want to testify? Okay. Okay. Well, thank you so much to this panel of witnesses. Thank you for your testimony. Or do you have her testimony? Okay, great.
Good morning. How you doing? I saw. Kind of nervous. This is my first time doing this. Good morning. How you doing?
Good morning.
It's my first time here, so I'm kind of nervous.
It's okay.
I'm trying to do my best. I start from here. Thank you. Chairperson Henderson, a member of this community, thanks for opportunity to share my experiences today. My name is Ana Jimenez, and I am a Ward 1 resident. I have worked as a home aide for 16 years. I usually work from 8 to 4. And afterward, I pick up my children from school and take them to the activities, including ballet classes for my little girl. I love my job because it's give me flexibility so that I can take care of my children, attend to my own medical appointment. I need back my therapy that I received sometime 3 times per week. I suffer from early arthritis and I'm really on regular treatment and medication to manage my painful condition so that I may continue to work in my job that I request helping my wonderful patients in the daily activity like walking, bathing, eating. I want to share how I feel when I believe I have lost my health insurance, which I have through DC Medicaid. I cry. I was overwhelmed, and I feel desperate. Desperate. The truth I losing my access to my doctor and medicine made me feel like I could not survive. I cannot get out of my bed because I was so worried. I truly feel my body was collapsed to the floor at any moment and read a letter that I received in the mail that I could be losing my Medicaid. But it's because I only read the first part of the letter because I feel so overwhelmed. At first, I did not read the second part of the letter until the next day. Something inside me told me that I should read the back of the letter. I feel immediately joy when I see the plan.
I especially feel that everything will be okay for me, for my family. And I feel very blessed that my children still have Medicaid. But also learned in the letter that Healthy DC plan does not cover dental care. And I was very concerned because the last time I was at the dentist, I learned that I have cavity, and I went to my clinic and told the Social Security about the situation. I was surprised when the social worker told me to go to the Ben Chili Bowl right away for help from the DC Health Link team, who would be then in person. I truly my Social Security and do not live too far away from Ben Chili Bowl, so I decided to go. I have some trouble finding parking because of the ice and snow, but I arrived safely, and I met a kind woman who explained why I could need to get separate dental insurance. Enroll right away. There in coverage started this past Sunday. I will have to pay a premium, which I am scared about, but I am very happy that I can see dentist this month. Please understand that my paying for this new premium will not be easy, but I feel it is important for me to always pay my bill. My rent extremely high, and for the first time, for the first, no, for the first time in my life, I have felt behind. I applied for rent assistance and I follow the rules, but I learned that I do not qualify. It has been very stressful trying to balance back on my work as a homemaid, child care responsibility, and my health. Thanks to Healthy DC. Thank you for listening to me story.
Thank you. Thank you so much again to this panel of witnesses for your testimony. Mr. Honey, I know your wife's business because I had a Wednesday or two of those. So it's very cool to, while you're not
on the word.
pass on the word. You're not the maker, but do pass it on. But I think your testimony about the impact on small businesses and healthcare is an important one, especially sort of this idea that someone's health insurance premium would cost more than a mortgage. Like that to me, I think on its face, anyone should think that that is ridiculous. Like your health insurance should not, right? And this is just the insurance, right? This isn't you had a surgery. This isn't some major hospital stay. This is just to have the thing just in case you might need it one day, right? And I think that speaks to the astronomical cost, but also the impact when Congress doesn't extend something like the premium tax credits, which here in DC impacted a lot of small business owners who were able to get their health insurance through the exchange from that way. So I hear you in terms of the desire to keep premiums low and what that means for small businesses altogether. Roberto, thank you for being here, for providing your testimony as well. And it's something we're continuously working on. And Chioma, you had a lot of questions, but I don't have a lot of that kind of time. So, but it certainly heard. Ms. Jimenez, something that you brought up in your testimony about the letter that you received. This is actually a conversation I was just having with Director Pierre for the Department of Human Services, different than Health Benefit Exchange, but everybody's sort of in the same cluster around how do we communicate in a way that doesn't dismiss people from finishing the information. So for example, we'll send a postcard that is nothing but words. And for most of us, our immediate thought is to say, like, wow, I'm not reading all that, right? That is just sort of the immediate response. If we get something that's just like all of on a postcard, it's just like, oh, okay. Are we providing information that is easily accessible to provide direct information about what people need to do to X, Y, or Z, right? So if you're sending me a note that says, I'm not in compliance in terms of TANF, perhaps you need to tell me exactly, first off, why am I not in compliance? What documentation is missing? Can the notice not be more personalized such that I can easily remedy the situation? And as there are a number of changes that are going to be occurring across the Health and Human Services cluster, our communication with people in a proactive way just have to get better, especially since we also tend to use so many acronyms, which most people don't know what we're talking about. So thank you for highlighting that and making sure that that stays on top of our mind rather, over the next few weeks and the next few months is like, how do we communicate with people? Because just sending an email and assuming that's covered your basis, even though it wasn't readable, it didn't answer questions, it wasn't using language that people can understand, it didn't provide a phone number to follow up, nor did it just say specifically like, what's missing? You told me I'm not in compliance, but then you don't tell me what I'm missing. So then I have to call to the call center and wait, and we just have to get better. So anyway, thank you so much to this panel of witnesses. Thank you for being here. Okay, we're gonna go to our virtual witnesses. For those who are joining us online, if you haven't done a virtual witness before, you have to affirmatively accept our invitation to become a panelist. There'll be a little box that pops up for you to be promoted. So we're gonna do 6 folks. Actually, we'll do 7 and then we'll go from there. So Violet Chiruno, Tripti Patel, Elam Kosarabe, Chinnery Hubbard, Jay Yarbrough, Carlos Plazas, and Veronica Hernandez. We'll give it just a minute for folks to enter into the room. Okay, we see a lot of you in the waiting room. You got to accept our invitation to become a panelist. Or Valletta. Okay. Okay. I don't see Valletta, but I do see Trupti. So Trupti, when you're ready.
Good morning, Chairperson Henderson. My name is Tripti Patel, and I am a 4th-term Advisory Neighborhood Commissioner representing Historic Foggy Bottom in Ward 2. Thank you for the opportunity to testify in the performance of the DC Health Benefit Exchange Program and to align my comments with this committee's priorities around health equity, affordability, system modernization, and accountability. This testimony is also my lived experience with the challenges of navigating the exchange to access healthcare. First, on health equity. The Health Benefit Exchange is a critical access point for residents who do not qualify for Medicaid and lack employer-sponsored coverage. While enrollment numbers remain strong, overall coverage gaps persist by ward, income, language access, and race. Residents continue to experience churn because of paperwork barriers, life changes, and renewal confusion. My concern is that equity outcomes are not consistently reported in a way that allows the council to track whether enrollment gains are reaching the communities that need them the most. I urge the committee to require clear, disaggregated reporting so equity is measured, not assumed. Second, on affordability. Premium subsidies have helped many residents, but affordability does not end at the monthly premium. High deductibles, out-of-pocket costs, and limited provider networks remain real barriers to care for many working residents, especially tipped workers like myself and small business employees. Coverage on paper does not always mean care in practice. My premium doubled from what I was paying last year, as well as my deductible and out-of-pocket expenses. So now for me to go visit the doctor, instead of $40, I am now paying $80. My medicine is much higher. Oversight must focus not only on access to plans, but on whether these plans are actually usable. Third, on system modernization and customer experience. Residents regularly report difficulty navigating enrollment, correcting errors, and coordinating between Medicaid and private coverage. These challenges point to aging systems that undermine both consumer confidence and administrative efficiency. If the district is serious about improving service delivery, the health benefit exchange must be included in the city's broader modernization efforts with clear performance benchmarks. And I have experienced this myself when I got kicked off of Medicaid, but no one told me. I found out through a provider, and transitioning was actually helped. Fourth, on navigator and workforce capacity, community navigators are essential to successful enrollment, yet they remain under-resourced and stretched thin, especially during open enrollment and renewal periods. This most directly affects seniors, immigrants, and residents with limited English proficiency. Stable funding and clear performance expectations are essential if we expect navigators to meet community needs. Finally, on accountability, this council needs standardized performance data that clearly connects budget investments to outcomes like retention, equity gains, and consumer satisfaction. Without that transparency, it is difficult to evaluate what is working and where course corrections are needed. In closing, the DC Health Benefit Exchange is not a website. It is a cornerstone of the district's health equity and affordability strategy. With stronger oversight, targeted investments, and clearer accountability, it can better serve the residents who rely on it most. Thank you for your time, and I look forward to continue to work with the committee.
Thank you. Elam? Okay. Elam, we see you in the waiting room, but you haven't accepted our invitation to become a panelist. So if you do so, we can certainly turn to you. Ms. Hubbard, I see you.
Good morning. Good morning, Chairperson Henderson, members of the Committee on Health and Staff. I'm Chinyere Hubbard, President and CEO of the DC Chamber of Commerce. And on behalf of our more than 1,000 members across all 8 wards, employers, large and small, thank you for the opportunity to testify today. We are pleased to support the DC Health Benefit Exchange's performance over the last year. In particular, the Small Business Health Options Program, SHOP, the health coverage provided to thousands of our small business employees, is important more now than ever to small businesses and district residents. We have received positive feedback from our small business members enrolled in the DC Health Benefit Exchange Authority's online health benefits market, DC Health Link. And we continue to encourage our small business members who are not yet enrolled to give it serious consideration. Throughout the year, the DC Chamber has continuously partnered with DCHL through virtual and in-person interactions and web-based information sessions designated to educate small businesses about their critical healthcare coverage options. These initiatives promote our joint business health insurance enrollment campaign during open season, including direct outreach to hundreds of DC Chamber members to inform them of their benefits offered by DCHL. Within the past year, we have sent marketing and promotional emails and social media messages to our small business partners, in-person connections, and referred hundreds of businesses to DCHL. Additionally, the Chamber worked in close collaboration with the DC Health Benefit Exchange Authority on 2 significant policy fronts. First, we helped to work to ensure that DC health insurance market includes only high-quality, comprehensive coverage offerings, not so-called junk plans that offer poor value and insufficient healthcare coverage for DC residents and workers. Second, over the last several months, the Chamber has engaged in targeted, data-driven advocacy through outreach to our Chamber colleagues across the country to extend the federal health insurance tax credits that have provided an affordability lifeline for many district residents, small business owners, and their workforces. For greater exposure, the DC Chamber newsletters and virtual convening announcements feature DC Health Link banner as a tagline, directing businesses to their website. Also proud to note that 2 of our 3 carriers, CareFirst Blue Cross Blue Shield and Kaiser Permanente, are members of the DC Chamber. Each of them works to inform small businesses of both the changing commercial health insurance landscape and accompanying market trends. The DC Chamber is committed to our productive partnership with DC HealthLink, one that provides robust, high-value small business health insurance coverage options to our businesses and their employees. And we look forward to continuing to work with the DC Health Benefit Exchange to maintain a high-value health insurance program for DC small businesses, their employees, and their families. Thank you for the opportunity to testify today, and I'd be happy to answer any questions you may have.
Thank you. Jay Yarborough.
Good morning, Chairperson Henderson. My name is Jay Yarbrough, and I serve as the manager of the DC HealthLink Assister program at Whitman Walker Health. Thank you for letting me testify today in support of the DC's Health Benefit Exchange Authority and to share our experiences as a assister organization. Whitman Walker provides affirming healthcare to more than 25,000 patients each year across the district. Nearly 20,000 individuals rely on us as their medical home, including about 5,000 folks living with HIV, and more than half of our patients identify as members of the LGBTQ+ community. Through our sites in Ward 2 and Ward 8, we provide primary care, behavioral health, dental care, legal service, and insurance navigation to residents of every ward of the city. Because of the ACA and the district's strong commitment to coverage, thousands of our patients have been able to obtain and maintain health insurance. That commitment has made a real difference in people's lives. However, over the past year, the district has experienced significant policy shifts affecting Alliance, Medicaid, and a transition to the basic health plan, the Healthy DC plans. These changes include adjustments to eligibility thresholds, requirements, and transitions between public programs and qualified health plans. While these policies are designed to maintain coverage, they have also created understandable confusion for many residents who we are seeing receive notices that are highly technical or difficult to interpret. As a result, people often don't know whether they have lost Medicaid coverage or been enrolled into a new plan, or need to take extra steps to keep that coverage. In many cases, people are only realizing they have lost coverage when they show up to a pharmacy or show up for a medical appointment. These challenges are not simply administrative, they are health equity issues tied to health insurance literacy, access, and language barriers. This is where DC HealthLink assistants play a critical role. Assistants help translate complex policies into clear information. We help residents understand their options, complete required documentation, and make informed decisions about their coverage. Whitman Walker Health proudly serves as a DC HealthLink assister organization since the exchange launched in 2013. I will close by reaffirming our deep appreciation for our partnership with DC's HBX and our continued collaboration with DC, DHCF, and ECA. At a time of significant policy transition and operational complexity, this partnership has been essential to maintaining coverage stability for district residents. Whitman Walker strongly supports policies that strengthen and stabilize the health insurance marketplace, improve affordability, and reduce administrative barriers that prevent consumers from accessing and maintaining coverage. We appreciate the exchange's ongoing commitment to consumer assistance, including its investment in sustaining the DC HealthLink Assister program and ensuring that trained experts remain available to serve residents. And with that, I will close and thank you for allowing me to testify.
Thank you. Carlos? Okay. Veronica Hernandez?
Chairperson Henderson, members of the committee. My name is Veronica Hernandez. I am the Entitlement Manager at Mary Center, a federally qualified health center serving the DC metropolitan area. For nearly 14 years, Mary Center has partnered with DC Health Benefit Exchange Authority to help district residents access affordable health coverage. We currently employ 2 in-person assistants who implement our health benefits exchange program and provide direct enrollment support to our community. At Mary Center, we witness firsthand the difference this program makes. Our in-person assistants help individuals and families enroll in coverage through DC HealthLink, the Affordable Care Act, DC Alliance, and Medicaid programs. We offer both in-person and televoice appointments to accommodate clients' needs and preference. Our team is well prepared, and the DC Health Benefit Exchange Authority provides a strong, consistent training to ensure we can effectively respond to the community's evolving insurance enrollment needs. In fiscal year 2025, our 2 assisters support 3,801 DC residents. This includes 634 new DC Alliance applications, 1,002 renewals, 332 new Medicaid applications, and 322 Medicaid renewals. Overall, 2,290 DC residents were successfully enrolled in medical coverage programs. Beyond enrollment, the team provided 1,511 consultations focused on health literacy, benefits status checks, and troubleshooting cases involving renewals, eligibility changes, and coverage transitions. Outreach remains central to our work. During fiscal year, our team participated in 42 outreach events across the district to help reduce the number of insured residents. In partnership with the DC Health Benefit Exchange Authority, we launched open enrollment strategic planning summit. We were reviewing updates to the DC Alliance Medicaid programs and prepare for implementing the Healthy DC plan for DC residents who are no longer eligible for Medicaid. The transition for individuals moving from Medicaid to the Healthy DC plan has been smooth overall. Our team has played an important role in providing detailed information about program changes, explaining the coverage available under the new plan. However, one of the most common concerns we hear related to the dental and vision services. The services are not currently covered under the Healthy DC plan. Many participants have shared that the out-of-pocket costs for dental and vision care are expensive and difficult to manage. They have expressed a strong interest in seeing these services included in the program. We respectfully encourage continued evolution of opportunities to strengthen coverage options under Healthy DC plan to better meet the needs of DC residents, ensuring comprehensive and accessible coverage support not only individual health, but the overall well-being and the stability of our communities. We deeply appreciate the partnership and leadership of the DC Health Benefit Exchange Authority. Their unwavering commitment to training and supporting our staff has been crucial in enhancing our ability to serve the community effectively. Thank you for the opportunity to testify. I'm happy to answer any questions you may have. Thank you.
Thank you. Thank you so much to this panel of witnesses for your testimony, bringing up a variety of different issues, affordability being key, whether it's for individual, which Ms. Patel, you brought up, or for a small business, which Ms. Hubbard, you talked a lot about as well. I don't have any specific questions for you all for this panel, but thank you so much for being here. And if you haven't provided your written testimony for the record, please be sure to do so. Okay, we're going to go to the next panel. Floyd May, Janice Davis, Kristineth Granidos, Nicole Quirago. Apologies if I am butchering. I'm doing my best. David Diaz and Serena Roy Roberts. Again, there'll be a little box that pops up that says, ask you if you want to be elevated to be a panelist, and you do have to affirmatively accept our invitation. Okay, we've got a few folks coming in. I see Mr. Floyd May.
Good morning, Chairperson Henderson.
Good morning. I can hear you, but I can't see you. And maybe that's on purpose, but.
Oh, no. There we go.
Ah, there you go.
There we go. Okay.
All right. When you're ready.
Good morning, Chairperson Henderson and members of the DC Council Committee on Health. I am Floyd O'May, the Executive Director of the Leadership Conference for Healthy Communities. LCHC continues to focus on reaching the hardest to reach, especially in the African American population. We have maintained a regular presence in locations that are accessible and convenient to persons needing to enroll or obtain information regarding health insurance options through the DC Health Link, including at the Martin Luther King Library, the Department of Employment Services, and AVA Healthcare. Additionally, we participate in virtual one-touch events. Early in the grant period, LCHC assisters made outreach calls to healthcare for child care workers, DACA, and we received over 60 calls made to DACA recipients, and approximately 72 calls were made to healthcare for child care workers before our focus shifted to assisting federal employees and federal contractors in the We Care campaign who were losing their jobs, thereby losing health insurance coverage. LCAC received over 86 calls from federal workers and contractors seeking information about available options for their healthcare insurance. LCAC disseminated information at beauty shops and barbershops in several wards throughout the city and tabled at a barbershop for 2 consecutive Saturdays. We arranged to have Lido's Pizza place 500 DC HealthLink open enrollment stickers on pizza packaging throughout the entire week, and we worked at Ben's Chili Bowl, including the last push on the open enrollment calendar. We enrolled over 433 consumers in Medicaid, 38 in the Alliance, 9 in the qualified healthcare programs, and 2 in the cover all plans. Additionally, our assistants provided over 1,500 people with information regarding the DC Health Link and made 304 calls to assist consumers. LCAC actively participated in many outreach events at the request of the HBX, including the Mayor's Winter Community Resource Fair, the Latin American Youth Center event, the Economic Improvement Summit, the Power Up for Success, the Small Business Expo, and the Mayor's Civic Learning Day program. We commend the leadership and the staff of the Health Benefit Exchange in this critical work and helping to improve the health and welfare of individuals in the District of Columbia. And I am open to receive any questions you may have about our activities.
Thank you. Ms. Davis. Janice.
Morning. I hear an echo. Okay. Good morning. I am pleased to appear before you today. Do you hear an
Janice,
echo?
hold on one second. If somebody else in your office is watching this, they need to turn it down or turn it off.
Yeah, perhaps that's what's going on. Thank you. It's off. No. Okay, hold on just a second.
Or mute the other side. No. Mute the second device. Or is the second device off? We can't hear you. So just unmute yourself. Nope, you gotta unmute. You're still muted.
Does that work? Nope. Yeah.
Do you want to try now?
Okay, is it working?
Yes, it is.
Perfect. Okay, good morning. I am pleased to appear before you today as a 4th-generation Washingtonian, Ward 4 resident and business owner, an insurance broker, and an employer whose employees are enrolled in DC HealthLink. I am a member of my professional association and represent brokers on the Health Advisory Committee and the DC Insurance Federation. I wear several hats: consumer, owner, consultant, fiduciary, and advocate for my profession, but most of all, an advocate for my clients. I can truly state that it has been a pleasure working with DC HealthLink and support its goals to provide individuals and small groups with medical, dental, and now vision coverage. Today, I want to discuss my participation in the Standard Working Group, which is comprised of carrier representatives, government actuaries, community representatives, university and medical professionals, and me, broker. We've been tasked to examine and develop plans, designs, and cost-sharing solutions that conform to actuarial standards, legislative changes, and also lead to improved health outcomes and health equity. DC is unique in that a majority of its residents have health care. With the most recent changes at the federal level, the subsidies, healthcare has become less affordable for individuals and small groups. In the past, this working group was able to expand access by reduced or elimination of copays for both office visits and prescription drugs, and also adjusting out-of-pocket maximums. These changes were aimed at reducing the cost barriers to treatment. We have tackled the issues like pediatric mental health, HIV, and those chronic illnesses that are prevalent in our population, including diabetes, heart disease, and high blood pressure. Although ACA plans have 4 metal levels, this year we have focused on the standard bronze plans. And I want to make everyone aware that these plans have deductibles from anywhere from $6,000 to $8,500, which is quite a bit. Our administration has, basically the government, has made an effort to make HSAs, or health savings accounts, the panacea for healthcare affordability. It's not the answer. Most employers and employees are not familiar with these savings accounts and cannot take advantage of them when faced with the cost of meeting these deductibles. Any plan modifications that we make as a committee have to have an eye to reducing costs. Oftentimes actuaries and people who are actually not in the field, or business owners, say, well, gee, we'll tweak this and tweak this. Employers and employees are looking at their bottom line. They want to reduce costs. And basically, healthcare in DC, especially for the small business owner, is not currently affordable. The carriers have developed programs that address some of these factors, social determinants. And the council, thank you, Chairman Henderson, and and Councilmember Parker, I know, have mandated coverage focusing on our community needs, like infertility coverage and now coverage for HIV. Please continue to do that, because these mandates are important, especially when carriers are looking at their bottom line and we're understanding the needs of our community. Again, however, annual rate increases, which range between anywhere between 6 and 13%, make coverage in DC unaffordable. We are seeing more and more individuals dropping out. Employers are making employees pay more or contribute more, or they're choosing frequently these bronze plans with extremely high deductible. We urge you as a council to continue your leadership, but we also want to thank the carriers and this whole cooperative effort, which is part of the standard working group, to continue to look at ways for reducing costs as well as providing access to promote health equity. It is my hope that interested and diverse and involved groups like the standard working group can recommend tailored solutions for our community. But again, we have to address the issue of affordability, and we have to have carriers as well as council members who understand that DC again is unique, but without the federal subsidies, and I heard a lot of other people testifying about the loss of the dental and the vision coverage, which is part of overall health, these things will not be possible. And I want to thank you again today, and thank you for letting me figure out where the echo was coming from. Thanks.
Oh, thank you. Kristen Yeth? Nicole? Okay. Nicole, we see you, but you haven't accepted our invitation. David Diaz? Okay, we also see you, but you haven't accepted. Serena Roy Roberts? Okay. All right. Well, thank you to Mr. May and Ms. Davis for your testimony and providing some feedback. Oh, Nicole has joined. Okay. Nicole, if you want to,
Can you hear me now?
yes,
Okay.
I can hear you, but I can't see you. And maybe,
Let me- Technology, God love us. Oh my God. Okay. Is that okay, Chairman?
yes.
Okay, good morning, Chairperson and members of the committee. My name is Nicole Quiroga, and I'm here representing the Greater Washington Hispanic Chamber of Commerce. Thank you for the opportunity to speak today about our partnership with DC HealthLink and the work we have accomplished together. At GWHCC, our mission is to strengthen the economic and social well-being of small businesses and the communities that we serve. Access to affordable health insurance is not just a public health issue. It is an economic stability issue. When businesses are insured, they're stronger employers. When families are covered, they are secure and more productive. This year, our partnership with DC HealthLink on 3 key areas: outreach, education, and trust building. First, we continue operating and expanding our one-touch enrollment initiative, offering both virtual and in-person enrollment assistance. We work closely with DC agencies, community organizations, and health partners to create a compassionate accessible enrollment experience. This approach removes barriers and made the process less intimidating for residents, and that's important, and business owners alike. Second, we integrated DC HealthLink into our broader business ecosystems. Through business expos, town halls, boot camps, networking events, and everything that we do, targeted campaigns, we ensure that health coverage conversations are happening where entrepreneurs are there. We embed the health access into economic development because the two go hand in hand. The most important thing, we focus on culturally competent outreach. We expand bilingual, which is important, bilingual assistance, and ensure Spanish speaking and multilingual business owners so that they feel they're included. Trust is essential in our community. Trust is essential in our community. Many small business owners operate with limited administrative capacity and uncertainty about regulatory challenges. Our role is to bridge that gap, and we do that every day, to translate policy into practical guidance. However, challenges still remain. Small and minority-owned businesses continue to face financial pressures. Looking ahead, GWHCC is committed to expanding in-person engagement, strengthening community trust, and aligning health coverage education with economic development initiatives. I'm here to answer any questions, and I thank you so much for the opportunity.
Thank you. David? Okay. All right. Well, thank you so much again to this panel of witnesses and for the issues that you raised, particularly, how this has impacted not just individuals, but also small businesses and the interactions that some of you have had with HBX, Mr. Floyd, talking about the Leadership Council and the work that you all do to help people sort of navigate the system. I don't have any specific questions for you all, but thank you so much for being here. All right. We're going to go to our next panel. Marcelina Romero, Sharice Crawford, Daniel Tyson, Adrian Smith, Paulina Barney. I'm actually just going to call the rest of the list. John Stevens, Lauren Barton, Latanya Johnson, Margarita DeLeon, and Claire Hyacin. Again, you have to affirmatively accept our invitation to become a panelist. Give it just a minute. Okay, let's see who we have. Okay, I don't see Marcelina. Don't see Sharice. Daniel. Or Adrian, but I do see Paulina. So Paulina, when you're ready.
Hi, thank you. Good morning.
Good morning.
Good morning, Chairperson Henderson, members of the Committee on Health and staff. My name is Paulina Barney, and I serve as the Director of Communications at Casa Lala Daycare in the Petworth community. Thank you for the opportunity to testify today. I'm here to urge everyone to protect, to fully support the healthcare for childcare, because it's one of the most practical and immediate ways that DC can strengthen childcare. Childcare educators do essential, skilled work, and yet for years, many couldn't afford accessible health insurance. We've had team members delay doctor visits, skip prescriptions, or try to make it work without any coverage. And I want to say this very plainly. When people who care for our children don't have health care, it sends a message that their well-being is optional and it should be protected. Healthcare for childcare has made a real difference in our staff and our program. When our educators learned that they could qualify for free or low-cost coverage, it brought immense relief and stability to our center. It also helps us recruit and retain great teachers and reduce turnover. Continuity matters in early childhood, and children thrive when trusted caregivers can stay. On a personal level, I believe that the coverage made possible through the Affordable Care Act has been instrumental in allowing me to achieve and maintain financial independence. I've worked in the field of early childhood education for over 2 decades, and I've been enrolled in the DC HealthLink coverage since 2019. Throughout this period, I've been able to be consistently satisfied with the support that I've received. Whenever I needed to make a change or seek clarification, I was able to speak directly with knowledgeable representatives, and they've helped guide me through the process. My interaction with DC HealthLink has been straightforward, it's been accessible, and it's been responsive to my needs and my center's needs. As more eligible educators sign up, we need DC to meet that demand and prevent barriers such as waitlist or coverage uncertainty. Please keep and sustain and strengthen healthcare for childcare so that we can keep experienced educators in our classrooms, building stability for children, families, and the childcare system that DC depends on. Thank you so much for your time and for the opportunity to share my experience with healthcare for childcare.
Thank you. Dawn? Lauren? Latanya? Okay. Margarita? Margarita, we see you. So if you're speaking, you're on mute. There you are.
Yes. Good morning, Honorable Christina Henderson, Chair, and members of the Committee on Health. My name is Margarita DeLone. I am a native Washingtonian, a DC resident, and small business owner. I also belong to numerous chambers of commerce in the district. Today, I am representing both the broker community and the DC Health Benefit Exchange Standing Advisory Board, of which I am proud to be a member. Brokers play a vital role as trusted resources for district residents seeking health coverage, and we also assist small businesses in setting up group health insurance benefits for their employees. I have also assisted healthcare for childcare businesses and their employees. Over the years, we have built strong relationships within the community, providing comprehensive education about the choices available in the individual market, the Small Business Health Options Program, SHOP, Healthcare for Childcare, and most recently, the Healthy DC Plan. Serving our clients effectively requires in-depth knowledge of current policies, recent changes, and the details of every plan offered by each carrier. We often serve as frontline interpreters of the ACA and marketplace policies, helping both DC residents and small business owners navigate complex information. Importantly, our work extends well beyond the open enrollment period. We do problem solving and supporting residents and business owners in a year-round commitment. Last fall, the DC Health Benefit Exchange introduced the new basic healthy DC plan. HBX prioritized early engagement with stakeholders and the community, including brokers, by seeking feedback through the Standing Advisory Board as the program was being developed. Brokers are instrumental in the process. Since my time is almost up, one thing that I wanted to bring forward, and this is kind of off topic, I urge the council to review and consider the adaptation of the birthday rule for Medicare supplements for DC residents. Currently, 750 DC residents turn 65 every day, joining the senior population and facing increasing healthcare costs. 12 states offer this highly desirable rule, which benefits seniors and compels insurance companies to offer competitive rates for products that otherwise hold seniors captive to ever-rising premium increases. I zealously advocate for the DC Council to study this proposal and consider passing the necessary legislation for our seniors. I also advocate for the continued support of DC Health Benefit Exchange in all the work that they do. Thank you, Chairperson and members of the Council, for granting me the opportunity to advocate on behalf of the broker community, the DC Health Benefit Exchange, and all DC residents.
Thank you. Claire?
Good morning, Chairperson Henderson and members of the committee, and thank you for the opportunity to testify before you this morning. I'm Claire Hyacin, a senior policy analyst at the Center on Budget and Policy Priorities, and I'm here today testifying as an individual and a DC resident. I'm also a member of the DC Health Benefit Exchange Standing Advisory Board and chair of the Standard Plans Working Group. The Standard Plans Working Group, which includes representatives from insurers, healthcare providers, brokers, and consumer advocates, meets once a year to update DC's essential plan design and consider ways to reduce cost sharing for more people. Thanks to the working group's recommendations, all essential plans now offer free or reduced cost sharing for people with type 2 diabetes, pediatric mental health conditions, cardiovascular and cerebrovascular disease, and HIV. Affordability initiatives like these are all the more important this year when marketplace enrollees are facing increased costs, eligibility restrictions, and red tape as a result of federal changes. Policy changes made by Congress and the Trump administration newly prohibit people with DACA status from enrolling in the marketplace and prohibit low-income immigrants from receiving the premium tax credit. Last spring, the Trump administration also enacted a new rule that makes ACA marketplace coverage less affordable for enrollees, more difficult for people to enroll and stay enrolled in, which will increase the number of people who are uninsured. And as a result of these and other policy options like tariffs and Congress's failure to extend the enhanced premium tax credits, underlying marketplace premiums increased substantially in 2026. And the Trump administration is now doubling down on this approach. They recently proposed a rule that would further increase red tape and expose marketplace enrollees to even higher costs. If finalized, this rule is expected to reduce marketplace enrollment by 2 million people in 2027 alone. Of particular concern, paperwork requirements are expected to drive disproportionate coverage loss among people with low incomes. Amid these attacks, it's crucial that the DC Council continue to support proven efforts to advance health equity and help people who are vulnerable to coverage loss. One of these initiatives is DC's Healthcare for Childcare program. Healthcare for Childcare is targeted, cost-effective, and has been held up as a national model for strengthening and stabilizing the early childhood education workforce. Ensuring adequate funding for healthcare for childcare will be especially important in light of these harmful federal changes that will make it more difficult and more expensive to get coverage through the individual market. Thank you, and I'm happy to take any questions.
Thank you. And thank you so much to this panel of witnesses. Oh, just kidding. Okay. We've been joined by Lauren Barton.
Hello. Let's see.
Okay, I think my video's on now. Sorry. Yep. Good morning, and thank you for the opportunity to testify, Chairperson Henderson and members of the DC Council Committee on Health. I come to you as a resident of DC and dependent on the healthcare provided through DC HealthLink. In the summer of 2023, my 20-year career abroad, working abroad, suddenly ended when a health crisis impeded my ability to work. I moved back to DC to be near my church community and to heal. When my employer-sponsored healthcare ended, the DC HealthLink made transitioning to a new provider very easy. The ACA tax credits helped provide a reasonable monthly premium I could afford as I began my freelance work in 2025. When the tax credits were not continued at the end of last year, a representative from DC HealthLink stayed on the phone with me until I had completed a new application to receive a different tax credit. Even though it's less than what I had before, it still helps me incredibly. And her perseverance with me, her patience with me was so helpful. As the daughter of a two-time breast cancer survivor, I need good health care for regular screenings. The care I've been able to receive using my marketplace purchase plan has been key to me keeping track with recommended care for cancer screenings, as well as rebuilding my health after my crisis in 2023. Thank you for working to improve our access to good health care, and please do what you can to make insurance premiums affordable for regular people living in DC. Thank you very much.
Thank you. Thank you, Lauren. Actually, your testimony was it was always good to hear about folks' interaction with our call center and our representatives, and it's good. Did you feel as though the person you worked with was knowledgeable? You said they stayed on the phone with you the entire time that you did the application?
She did, yeah. I had applied, and it was a for some reason it wasn't showing that I had tax credits, and so I called and she answered and was like, okay, yeah, we can definitely help that. Now we need to walk through this, and you need to do this, and you need to click. It was like, she said, oh, you can't do it from a phone, you need to do it from at least a tablet. I mean, it was so helpful. She knew exactly what she was doing. She knew exactly how to help me, and she was very patient and just like a delight to work with. It wasn't like I was bothering her or, ruining her day or anything for being stupid. It was like, no, this is what I'm here for, and I'm happy to help you. And that was such a helpful thing.
That's awesome. And that's also what we hope would happen anytime somebody has to reach out for government services.
Yeah.
Right? Like that the time that you do have to call, you want someone to, one, answer the phone, and two, be knowledgeable, but also pleasant through an experience. And so thank you for being here. Paulina, thank you so much for being here as well and providing the perspective from, a business owner or as someone who works in terms of the business. I'm assuming that, well, I don't want to make an assumption, that there are employees at Casa Lala who are enrolled through Healthcare for Childcare?
That's correct. At the beginning, were pretty reluctant, I think, because it was a relatively new program that they hadn't heard of. So I was actually the first person to enroll. And it somewhat snowballed, and one by one, more and more teachers have started to sign up. And actually, last night, two more teachers, classroom teachers, came out and said that they wanted me to sign them up as well. So I have a feeling that the majority of our teachers by the end of this year will likely be enrolled. They are a little bit above earning wage for receiving Medicare benefits, and this is a fantastic bridge as it makes coverage affordable for all of them. They're almost all receiving free health coverage through the Healthcare for Childcare with Kaiser.
Oh, with Kaiser. Okay. And I just want to state for the record for folks who think that Healthcare for Childcare is just an extension of Medicaid or another program. It is completely different. It is designed differently. And the businesses do have to have some skin in the game. So it's not 100% where, we're just giving healthcare, but it is setting up an employer-based system for a industry for which hasn't typically been able to have coverage either due to small numbers or because of the costs. So I think Healthcare for Childcare is probably one of the most innovative programs that we have done in my time as a council member, and I want to hold on to it for as long as we can. I don't have any further questions for this panel. Thank you all for being here. And thank you all for being here. Please just make sure you provide your written testimony for the record. Okay, we're gonna take a 5-minute break because we've been sitting for a little bit. We'll take 5 minutes, and then when we come back, we will have the testimony from our government witnesses. So 5 minutes. Thank you. Okay, and we're back. We're with Mila Kaufman, the Executive Director of HBX, to provide testimony. Before you begin, Director Kaufman, I need to swear you in. So if you raise your right hand, or you or any of the members of your team who may testify today, is it only going to be you? In theory. Okay. All right. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
Yes.
Awesome. Okay. When you're ready.
Good morning. Wanted to make sure it was morning. Good morning, Chair Henderson and members of the Committee on Health. My name is Mila Kaufman. I'm the Executive Director of the Health Benefit Exchange Authority. And I just want to, first of all, thank you for all of your support throughout our years of being here in DC and serving DC small businesses, nonprofits, and residents. I'm here to testify on our performance over the last year. Since I only have 10 minutes, I will not go through all of the details in my slides, but just highlight important information. And then hopefully we'll have a chance to go back and talk about some of the details. So who are we? And just a highlight of our record of success. As you know, we are the Health Benefit Exchange Authority. We are responsible for the online health insurance marketplace under the ACA here in the District of Columbia called DC HealthLink. And we have a long record of success, although we were the last to start building our IT system in 2013. We were one of 4 state-based marketplaces to open for business on time and stay open on October 1, 2013. We also successfully implemented major local coverage initiatives, and I'll just highlight one of them, Healthcare for Childcare. This is DC's locally funded health coverage program. You enacted legislation in June of 2022. We worked with the community impacted by Healthcare for Childcare, got a lot of input on how to design the program, a program that would work for both workers and employers in the early child development area. We opened the program a few months later on October 2022, and coverage became effective January 1, 2023. And most recently, this past year in 2025, we implemented a major new program under the Affordable Care Act here in DC called Healthy DC Plan. And I'm going to give you more details on that in a few minutes. We have been a successful ACA state-based marketplace, helping to achieve approximately 97% coverage rate for our DC residents. That's almost universal coverage. We cover approximately 115,000 people with private health insurance, more than 5,300 district small businesses and nonprofits. We work with more than 900 DC HealthLink brokers. They provide free help to our customers. We're responsible for approximately $800 million in annual premiums. And back in 2017, we formed a first in the nation state-based marketplace partnership with the Massachusetts Health Connector for Business. Now I want to spend the majority of my time this morning providing you an update on where we are implementing Healthy DC Plan. This is a program under the ACA, formerly called Basic Health Plan. As you know, the Medicaid eligibility in DC changed to ACA levels to ensure that residents continued to have affordable health care. We established a basic health plan, which is an option that the ACA provides to states. We received federal approval for our program in September of 2025, and we're very grateful to all the assistance we receive from the federal government helping us to establish this program so quickly. Funding is provided for this program by the federal government, and there is no local match requirement. Eligibility rules. The program, Healthy DC Plan, covers residents up to age 65 who don't have affordable employer-sponsored coverage or other health coverage. It is available to U.S. citizens, so residents with incomes over 138% of federal poverty level, up to and including 200% of federal poverty level. Due to federal law changes in the reconciliation law, also sometimes called One Big Beautiful Bill Act or OB3, there are changes to residents' eligibility for health, federally funded health coverage who are in the lawfully present category. And that eligibility initially changed starting January 1 of this year, and then there'll be further changes that come into effect in January of 2027. I want to clarify that those eligibility changes not only impact basic health plan under the ACA, but all of the ACA affordability programs, including the advanced premium tax credit or the health insurance that lowers premiums. And just a reminder, undocumented residents under federal law are not eligible for any ACA programs, and that continues to be the case. We designed Healthy DC Plan to ensure continuity of care and coverage, so there are no monthly costs, no out-of-pocket costs for covered care. All of the hospitals and community health centers that participate under Medicaid also participate in Healthy DC Plan. The coverage, the covered benefits are the exact benefits provided under the ACA on our commercial side. We automatically enrolled approximately 15,000 residents who lost Medicaid due to eligibility changes in the program. And coverage for Healthy DC Plan started January 1 of 2026. Currently, Healthy DC Plan covers approximately 16,000 residents. I'm going to skip over a lot of the data slides and happy to go back to those if you have questions. I want to share some early lessons we've learned. So we automatically enrolled residents who lost their Medicaid and who were eligible for this program. So that was a major benefit to ensure that people in DC, that residents had coverage. And we're very proud of that. We worked very closely with the Medicaid agency and Deputy Mayor Turnage and his team to accomplish that. One of the lessons learned early on for us is that we made the process so seamless that some residents didn't understand fully that they lost Medicaid and that they had new coverage. And so when some residents went to see their doctor in January and the doctor's office asked, do they have new coverage or has anything changed? Unfortunately, Healthy DC Plan enrollees in some cases said, nope, everything is the same. And of course, when their doctor's office checked their eligibility in Medicaid, they were no longer in Medicaid. So we had to take many steps to enhance our outreach to both clinicians as well as our enrollees to address that. And we worked very closely with many, including Dr. Bennett from DC Health, who sent multiple information bulletins to clinicians. We worked closely with the DC Hospital Association, DC Medical Society, DC Primary Care Association, and of course, all of our carriers. And I thank them for all of their efforts and all of the education they helped us do. A quick update and another early lesson on pregnancy transitions. As you've noted and others, it is very important to make sure that when a covered person becomes pregnant, that the pregnant woman has access to her healthcare provider, and that coverage changes shouldn't mean that she no longer has the care that she needs to stay healthy during pregnancy and have a good low-risk childbirth. And so we developed a very robust process with the DC Medicaid agency to handle those transitions. And that process is going very, very well. Another early lesson for us is federal law requires us to terminate coverage in the Healthy DC Plan program for residents that turn 65, because that's an eligibility requirement. So we partnered with the DC Healthcare Ombuds Office to help us. And we share information for affected residents. In addition to us sending information to those residents, the DC Healthcare Ombuds Office reaches out and assists those residents to help them enroll in Medicare, as well as enroll in qualified Medicare beneficiary program. We're very grateful to Maud and her team for their significant assistance with this population. I see I'm out of time. Should I keep going? Okay, thank you. Lots of lessons on automatic batch enrollments. As you know, we did 3 rounds of huge enrollments, meaning not one by one, but taking thousands of enrollees from Medicaid and transitioning them into Healthy DC Plan to make it very seamless. In the fall, we identified about 1,400 applications that we couldn't handle automatically. Each one needed a review because of, mostly because of data issues and the way that we saw information appearing. In December, when you held a roundtable to get an update from us, I mentioned to you that we wanted residents to read our information, read notices, and if they had a notice from us to come back and update their information to do that. And we did a lot of outreach around that because we're very concerned with our ability to get everyone in for 1-1 coverage, given the fact that there were 1,400 applications that needed manual review and work. I'm glad to report we were able to get everyone covered for 1-1 who was eligible. Unfortunately, none of our outreach efforts worked well, and no resident came in to do their own application. So that was a big lesson for us to try other mechanisms to reach this population. Another early lesson, and this is a population I'm very concerned about. We have approximately 2,200 residents we've identified who did not qualify for Healthy DC Plan. We do not know for most their coverage status. We are unable to reach most of these residents, unfortunately. Now, we've had a very robust outreach effort with multiple formal notices, more informal, easier to understand, shorter email communications, lots of calls, lots of texts. Our sisters, DC Health Link sisters, helped us with this outreach. We know the status of about 300 residents. Most of them we were able to enroll into one of the coverage programs, either commercial side or some because of income changes back into Medicaid. But for most of this population, we are not sure about their coverage status, and we're very concerned about that. Our board acted very quickly and added a new special enrollment period for this year. So anyone who loses Medicaid coverage can come in and get enrolled either on the commercial side or into Healthy DC plan. Another at-risk population I'm very concerned about is lawfully present residents whose incomes are under 100% of federal poverty level. Because of federal law changes, they no longer qualify for lower premiums or no-cost coverage. We've identified approximately 126 residents, and there are no coverage options for those residents currently. And then starting in 2027, I'm also very concerned about residents who are lawfully present, who will no longer qualify for Healthy DC plan. In January of 2027, anyone in the lawfully present category who, for example, if they're not a green card holder or fit one of the other two limited categories, they will no longer qualify for a Healthy DC plan. I'm happy to stop I will stop, and I'm happy to take any questions you may have.
No, thank you so much, Director Kaufman. I think your testimony and sort of all of the various issues that you covered and the programs that you do, it's actually kind of beautiful to think about the evolution of the Benefit Exchange Authority over time, in terms of just pure ACA to then we were like, hey, you want to provide a health insurance program for childcare? And then, oh, hey, we have this population of individuals that we need to be able to somehow transfer who are losing their coverage. Oh, hold on one second. We're going to try to figure out how we take this down from the screen so that folks at home can actually see us. There we go. Okay.
I was trying to do that myself and obviously could not.
No, it's okay. All right. So I have some questions for you to follow up on some of the things. And just as a reminder for folks, I think the slides as well as all the pre-hearing things that you provided to the committee are available on the council's website if folks are kind of interested in there. So my questions will just be a follow-up from some of those things that we talked about. Okay. So in the pre-hearing responses, you all indicated that there was approximately $90,000 in unanticipated overtime costs in fiscal year 2025. And already we're seeing for FY26 that overtime costs are already above what the agency had budgeted for, but that you can absorb those costs. What were some of the causes for the increased need of overtime? I think I know, but I just want you to say out loud.
Usually it's good practice not to budget for overtime, but in fact have the staffing levels you need.
Yes.
But despite of that, things happen and you have to be able to either handle an influx of cases that come in, new responsibilities that are enacted into federal law or implemented through federal regulations. And sometimes it doesn't make sense to hire full-time FTEs if you have a temporary need for additional staffing. And so essentially, we've experienced many changes, and I'm happy to give you more details during budget hearing. But to give you a sense, federal law changed. Locally, we were implementing a significant new coverage affordability program, and it did take time to hire staff to 100% focus on Healthy DC plan. While we were staffing up, we of course needed to serve our customers and new enrollees. And so we did pull staff from other programs and offered overtime to do to provide the service that our customers expect.
Okay.
So that drove much of the overtime.
Okay. In your pre-hearing responses under contracts, you have a contract with this, I think it's a company called Changing Technologies for temporary support staffing. Is that call center or was that for something else?
Our call center is through a large company called Maximus.
Okay.
And so they operate our call center for us. The other contracts we have for temporary staffing are generally, are not for the call center, but they help us with, for instance, return mail processing.
Okay.
Those kinds of functions.
Do we bring on extra people during open enrollment?
The call center does.
Okay.
To handle extra call volume.
All right. So obviously HPX gives out several grants to individual organizations to help with outreach, assistance, et cetera. Talk to me a little bit about how you all assess the success of whether or not the grantee met the goals that were outlined in the grant. And have you all had any issues thus far?
We do not have any issues with our grantees. We're thrilled to have the organizations serve as our DC HealthLink assisters. In fact, I think almost, if not all, then almost all have been with us since day one. And they do really, really hard work. They're on the ground. Many times residents don't want to call us. They have a distrust in government, they've had a bad experience, whatever it is, they really rely on our assisters on the ground to help them. And as you heard from one of our sister organizations, they not only enroll people into DC HealthLink, but if they figure out that someone is eligible for Medicaid, that they help that resident. They don't turn anyone away. So your question about how we assess success, we can't just look at number of enrollments into commercial coverage. We look at everything. Can they help us be in the community and be, table events and provide basic information? Can they do enrollment into different coverage programs, commercial to public insurance? So all of those elements are critical to us. And I also want to note, health insurance, it's not like a 5-minute conversation. So it's not like we're looking for thousands of enrollments. Right. We recognize that some of these cases are quite complicated. You may have members of your household who qualify for Medicaid and others qualify for Healthy DC plan, and yet others may qualify for DC HealthLink. And so it takes time to work with a resident to make sure the resident has all the information they need to make an informed decision and to help them online to get them into appropriate coverage.
So building upon that, you all reported approximately 1,000 more new individual market enrollees this year in comparison to last year. You obviously talked about this in your testimony, right? The national and local concern that people would opt out of health insurance coverage, but due to increased costs with the enhanced tax credits, et cetera. But then we saw some growth, and that could have been for a variety of different ways because there was so much movement across the system, right? We had a lot of, particularly here in DC, we had a lot of people who lost their jobs from the federal government or federal contractors who then had to pivot, and maybe that was their entrance into coming into the marketplace. You had the loss of the premium tax credits, and therefore some small businesses have to shift. Just a lot of shifting that was sort of taking place. Did the increase surprise you all in terms of what you thought might happen?
You've just identified all of the different factors that made this open enrollment, I would say, have more friction, for lack of a better word. Lots of changes. We attributed most of the renewals and the higher plan selections to the changes in the federal workforce, folks who were subject to the RIFs and contractors who were also impacted. Throughout the year, we noticed an uptick in special enrollment period enrollments. We attribute that we had, looking at this year's plan selections compared to last year's, about 2 to 3% increase. We attribute almost all of that to the changing landscape federally.
Okay. So for folks who are kind of paying attention, that doesn't necessarily mean that our overall number of people in DC who are covered by insurance somehow went up by several thousand. It just means that there were shifts in terms of how people were getting coverage.
Yes, and to add, these are plan selections. That does not mean folks actually paid their first month's premium and are still paying. And I want to underscore, when I say friction, until all the dust settles, meaning people pay their first month's premium, they continue to pay, we're actually not going to know the full impact of the expired federal tax credit. And especially with residents who signed up for bronze level, which has the highest deductibles among all of our coverage options.
Yeah.
Once they start seeing that they have to meet their deductible before coverage kicks in for many services, they may decide they cannot afford to pay the premium and meet their deductible. So we're paying attention to the data that's coming in, but we're not going to know the full impact. We did do a quick survey, and in my slides, I provide you with some preliminary data, which is very telling. Even looking at our new customers we surveyed, about half of them who dropped their coverage already told us that they dropped because they couldn't afford the premium. And these are new customers who signed up during open enrollment thinking they can afford the premium, and they dropped. Others told us they don't need it because they have job-based coverage or other coverage. But half of new customers saying they can't afford it, that's why they dropped the coverage they signed up for. That's a very alarming data point.
Yeah. That went through the process, signed up, and then circumstances changed, or personal finances changed for sure. We did see an increase in the number of individuals who were applying for ACA premium hardship waivers. So we had 13 in 2024, 24 in 2026, and so far we've already had 16. Is there a particular income threshold needed to apply for hardship waiver, or is that simply based on circumstance or incident that led to the hardship?
I will get back to you on the details of the qualifications.
Okay. It's fresh on my mind because we're having a conversation right now in terms of TANF and hardship waivers in another committee. So I'm like, what does hardship look like, and I don't know if there's a way to sort of streamline it across all of our systems. When you all receive appeals, how do you process those?
So generally, residents who believe they may qualify for a higher health insurance tax credit than our system shows, or sometimes when we're, during the year when we're not in open enrollment, a resident believes they qualify to come in, and if we decide at the staff level they don't qualify under the special enrollment periods, we get those types of appeals. So we get them internally. We try to resolve things if we can internally through different levels of process we have. If we can resolve it to the satisfaction of the resident appealing, then we can handle it at our level. Some cases we can't resolve, and those appeals go to the Office of Appeals, Hearings and Appeals. And those are administrative hearings, essentially, where we appear, the customer appears, and the administrative law judge ultimately makes a decision.
How often do cases make it that far?
We don't have many cases that go
all the way to
correct.
Okay, all right. I want to ask a couple of questions about call center operations. So the frontline employees in the call center are considered tier 1 responders. So it's not intended for them to be able to resolve all cases. Tier 2 is, sort of case manager, HBX employees. How often do calls rise to tier 2?
Many times. Because tier 1, they don't have access to the types of systems that they would need to resolve a case. So those are essentially shifted to tier 2 with the appropriate access.
Okay, so in the pre-hearing responses information that you guys give us about call center wait times and, in terms of that part, is that only reflecting from your initial dial to somebody picking up in sort of tier 1?
Yes, all of our tier 2 cases are handled by HBX staff. And so if our member services, for example, staff need more information from a customer, they'll reach out by phone or email to get more information. Sometimes our staff can just resolve the case without additional information. And then there's a loop back to the customer that it's been resolved.
Okay.
But generally, customers call our call center, and so the wait times, all the data points you asked about the call center, that is strictly tier 1.
Okay, so we'll follow up with some questions in terms of the tier 2, specifically around just like how long does it take usually for you all to reach a resolution, maybe and not how long the call, but if there's a back and forth type of deal that it opens up a case, how long does it take for us to resolve that part?
Yeah, I can tell you, many cases that come to tier 2 involve us communicating with our health plan partners.
Okay.
And so there's time that our health plan partners need to investigate and resolve things on their end. In addition, some tier 2 cases involve IT issues. And so there may be a problem with someone's account. Let's say they opened an account in 2013. They had coverage somewhere else for many years. Now they're coming back and they're trying to reuse all of their old credentials. That is not, we're not going to just let you in, right?
Yeah.
There needs to be a process, and that process may require our IT team to put in, to resolve a ticket.
Got it.
Even our tier 2 member services staff cannot resolve certain IT issues. So there is no
average wait
typical.
time.
And many times, even if we can just really quickly figure out what the problem is, but we need additional information from a customer, we reach out, we wait.
Yeah, you can control that part.
And we follow up, and we follow up multiple times. We've had instances where we just closed cases because we couldn't get the information we needed.
Yeah.
So it's tier 2 cases are really hard to give you data on because they're just
I would tell you that, like,
wait points.
overall, we're doing excellent in terms of call center wait times and operations. And I'll just give you an example. On the federal government side, I had to call the IRS about something. It was one question. One question. I was on hold for 2 hours to just ask my one question that I couldn't find on the website, right? Like if I could have a website, a chat box, give me something else. But the fact that I was on hold for 2 hours just to talk to someone at the IRS was just wild to me. So when I see these like, someone had to wait 6 minutes, I'm like, 6 minutes? That's a breeze. 6 minutes. You could, well, actually, it's longer than that. We're more like 12. But nonetheless, it's not that bad at all. Okay.
And if I can just add, so I'm glad to hear positive feedback from you, but I just want to recognize that I also, as a consumer, have expectations. And if I call our call center, I don't want to be waiting for 2 hours ever, right? So we are always looking for ways to improve our customer service experience at the call center. And we're working with our vendor to improve the staffing levels, to have more customer service representatives at the call center. We've also implemented callback features. And so if you're on hold for 60 seconds, our system gives you an option for a callback. You stay in the queue, you don't have to lose your place, and someone calls you back. And then when we have higher than typical call volume, we put an alert on our website to let customers know that we're experiencing higher than typical call volume. Also to help inform our residents who rely on us for quick service, as well as small businesses and nonprofits who can't wait for 2 hours. So we're always looking for ways to improve.
Yeah. Let's talk a little bit about benefits. So I find it interesting that 1,900 people have purchased dental-only plans on DC HealthLink. Now, this number could reflect Medicare beneficiaries purchasing separate dental coverage because Medicare does not include dental coverage. However, it's one thing to have coverage, it's another thing to use it. I guess HBX doesn't get any claims data, so you wouldn't necessarily know if somebody actually utilized the insurance that they purchased.
For dental?
Yeah.
That's correct. So before we existed, there was no opportunity for residents to purchase dental coverage on their own. The market on the individual side did not exist. You can get dental through group, through an employer, but it was not sold individually like health insurance was. But of course, you needed to be in perfect health to get it before the ACA. But with the ACA, when we built our marketplace, we also built in features where residents could just buy dental. We at that time didn't fully appreciate that there was no individual market for dental. And so we created a whole new private market where even if you're on Medicare, which doesn't cover dental, you can get your own dental policy. We have people with job-based coverage whose employers don't provide dental. They get dental coverage through us. We've also actually had some people who are in the Healthy DC Plan program who decided that they needed to buy the standalone dental and are fortunately in the position to be able to afford the monthly premium.
Are there, what's the average cost if you were just to buy standalone dental?
I would have to get back to you. It really depends on how much out of pocket you want. So there are lower cost dental plans and higher cost dental plans. Depends on how much coverage you want.
You know, it's so funny. Everybody always talks about how young people, high school students need financial literacy classes. And like part of financial literacy also needs to cover like how insurance works, because the understanding of a premium versus a deductible, how to read your explanation of benefits to even know, does it cover all the things that you think you might need it to cover? What's a good plan versus not? What's a junk plan? X, Y, Z. Like there could be a whole class on just trying to sort of navigate some of these pieces. And we just kind of leave it to people and say, good luck to you. That's not an indictment on HBX. That's just sort of in general, like this could be very complicated for somebody to sort of try to navigate on their own, which speaks to the importance of assisters and brokers.
I would support the idea of requiring financial education at the high school level to include insurance education, especially health coverage. On our website on dchealthlink.com, we do have tools, consumer decision support tools that are designed to make it as easy as it can be to choose the best option for you. When a consumer doesn't want to work with a broker, and some do and some don't, they do need tools that could help them make informed decisions. So we have health plan match, we have dental plan shopping to make it very easy. So if you're only looking for dental coverage, you can choose dental and put in a few specs about yourself, and then it will instantly show you some good matches. So we try to make it very easy. And then to your point about how difficult health insurance is, over the years, we've learned that there are many people who use our assisters who are 20-something. So when their mom usually isn't helping them to enroll, this is the first time, especially as they age off their parents.
I know, you hit 26 and they say you gotta go.
And it's a hard decision. It's not something the schools or colleges help you learn. And so they need help, and many prefer the in-person help. And so it's an interesting population, because you would think 20-something, they never want to talk to another human being. They prefer to do everything on the computer, right? That is not our experience.
That's interesting. That's an interesting reflection. And, you know, I'm talking about sort of high school students, but maybe this is like something for college. You know, when you are a senior in college or you're graduating from college, if you have student loans, everybody has to go through this like exit education program where they say like, now let's talk to you about your student loans. Let's talk about payments and what does default mean, or forbearance, or what are the particular options. And they just probably need to add healthcare to that of like, hey, you have a couple more years on mom and dad's insurance, but when it ends, it ends. And hopefully you are established, but if not, I don't know, but I'm glad that this is available to folks. I want to follow up on something in terms of benefits and services. So last year we discussed the issue around, you know, HBX in DC. We have made some decisions around certain benefit offerings not having cost sharing. So for instance, for young people, for mental health services to be able to see a doctor and not have to pay the copay, but that some providers have added this, either a facility fee or a file fee or something else, where they're recouping some additional costs that were not originally contemplated, because we wanted to make accessibility as seamless as possible. What, if any, work has HBX done with DSB around this practice that we're seeing, where, yeah, your doctor's visit didn't cost any, but thing, but now you have to pay a facility fee of $25.
Yeah, this has been an ongoing frustration for us too. These facility fees are market-wide. They're not unique to exchange products. And so they require a market-wide solution.
Okay.
Now, when you talk to providers, when I talk to providers, I hear they need these facility fees to survive. But on the other hand, for enrolled residents who expect co-pays, co-insurance, deductibles, they don't expect some of these other surprise fees.
Yeah.
So it continues to be an ongoing challenge. That's a market-wide issue to resolve.
All right, well, DISB is now part of our committee, so we can have this sort of larger conversation, because it's not just facility fees. I had this, we had the hearing for DC Health maybe a week or so ago. And we talked about this in terms of the universal health certificate and the required dental forms. Well, we require this universal health certificate, and we definitely have pediatricians' offices who charge to fill out the form, which is required in order to go to school. And then parents fill out, or parents pay, they get the form, and then nothing happens with the form because now we have to pay a nurse to enter the data. Like, the system just doesn't make sense to me, particularly in the age of 2026. Why technology cannot just speak to one another in terms of the systems, right? All we are trying to figure out, did your kid have the required vaccines that they were supposed to have? Why do I have to pay $10 for the pediatrician to say, yes, I gave my child a shot? So I think overall, and some of these extra fees, it's giving restaurant industry to me, where we've seen restaurants who add all of these like additional facility fees, convenience fees, X, Y, or Z. And I hate to see that happening on the healthcare side where people actually need their services. Because it comes as a surprise to some folks, as you said, who like, oh no, I'm not supposed to have a copay. And it's like, oh, well, sorry. You know, okay. In terms of benefits, we're excited to see the uptake in the fertility benefit that we offered. 971 individuals with a confirmed claim. Now, we just had the performance oversight hearing with Department of Insurance, Securities, and Banking, but I want to check with you all as well. What's your process of sharing residents' complaints around the challenges with accessing that new benefit? So anytime we introduce something new to the system, it takes a little bit to trickle down, especially in a large behemoth insurance company, right? The person who is answering the phone may not be completely aware. What has been the experience of HBX when you guys have gotten any phone calls from individuals about their insurance company saying either A, they don't qualify, or B, they don't offer it?
So we have a process with DISB and appreciate the staff level work we do with them. Anytime we get either direct customer issue, complaint, problem, sometimes we get questions about what the new benefit actually means. We work very closely with the DISB team. We rely on the DISB team to issue market-wide guidance. We can't go interpreting something just for our customers, right? This is a market-wide requirement, and DISB is responsible for the oversight and interpretation of what it means. So we rely quite heavily on them. We share questions we get and issues we get with them, so they are aware and then can address them market-wide.
Okay. You flagged in your performance oversight hearing responses that there's a new proposed rule by the Centers for Medicaid and Medicaid Services that would essentially reverse a Biden-era decision that didn't require the district to continue to pay for the fertility benefit. Are there any other benefits that the district added to the essential health benefit list that would be affected if this CMS rule were to go into effect?
We're only aware of this particular one.
Okay.
And we will be submitting comments. We are hoping to educate the federal regulators a little bit more about what led up to the new benefit here, fertility treatment, how it's benefited DC residents and workers and employers, and also work with the federal administration to figure out if they can, if there's a different alternative available to them. They're seeking to balance the use of federal health insurance tax credit and keep premiums as affordable as possible, balance that with the need to provide coverage that works for all families, including families who are trying to have a baby. So we plan to do more educating and hope to see some alternative finalized and not as proposed.
Oh, I appreciate you all taking that on. I believe President Trump might have referred to himself as the godfather of IVF. And it would be unfortunate that a rule of CMS would knock out that coverage for the nation's capital, which also would include some members and staff of the Congress. So as much as we can educate them on this decision, that would be good. Let's talk about healthcare for childcare really quickly. So I think you said there's only one facility that's currently on the wait list. That group's, we're able to accommodate that group, and their coverage will become effective April 1. Look at that. Nobody on the wait list.
There's no.
Now, I know that we had some testimony earlier that there are definitely some facilities that are still eligible. But I don't expect every facility that this would work with their financial model or otherwise. It really is a decision that the owners and operators need to make in the same way that any small business would need to make. Correct?
That's correct. And when the funding stream changed, we changed our approach. In the early days, as you remember, we approached healthcare for childcare very much from a sales perspective. We went out at least 5 times in person.
Yeah.
We called, we did a lot, we invested a lot in outreach to try to make a sale to essentially convince an employer who's never offered coverage before to start offering, and that's a major decision, or convince employers who were offering something to consider healthcare for childcare because it was better coverage. And that was a big sell, and it required significant resources from my team. When the funding stream changed, we determined that we shouldn't be engaging in that kind of strategy because the best we can do is offer someone to be on the wait list.
Yeah.
And that is not the way you close a deal.
Yeah, you get them all excited and you're like, and you have to wait now.
It's a complete waste of their time, right? As an employer, to even spend 5 minutes on something they can't get. So it was just not gonna be our strategy after the funding stream changed. So we know that there are businesses who are still eligible, but we're not doing any outreach. And unfortunately, when providers do come to us, at times we have to put them on the waiting list.
Yeah. I have a question. So what we were able to accomplish with healthcare for childcare, are there other industries where individually it wouldn't work for that particular small business, but if they were able to pool with a couple of other businesses that are similarly sized, et cetera, they would be able to pool for a better health insurance premium or cost as a small group? Have we thought about this for any other industry?
Well, so healthcare for childcare is part of our small group market.
Right.
And so their claims, they're in the big pool of over 100,000, right? So it's not like they get individually priced in any way.
Right.
But this model of if there's limited funding available, and the limited funding means you can, decrease like the entire population by $1, that doesn't help anyone. So when there's limited funding, you want to start looking at industry by industry, who you can help them, the most. Instead of helping everyone with $1, you help an industry with significant savings. And so this model could be used for others as well, other industries. And we've talked to other states with limited funding, both interested in healthcare for childcare model and what DC policymakers here and we've done to operationalize it, but also looking at limited funding, how our model could be applied to other industries.
Okay.
And any state with a state-based marketplace can do what we've done. It is much harder for states that rely on healthcare.gov because that's a one, IT solution that has to work everywhere. For us, because we have a local IT system.
nimble.
Exactly. That's how we were able to implement healthcare for childcare so quickly, actually apply the discounts on premiums by modifying our IT. That's how we were able to implement Healthy DC Plan so quickly, by modifying and prioritizing on our IT roadmap the modifications to make it work.
Again, I go back to the beginning, like our decision to do our own marketplace. We didn't know at the time, you guys had no idea at the time that we were launching this, like we're gonna add some future plans to this, but good foresight on our part to allow for that type of flexibility. On that, I want to ask some questions about Healthy DC. And first, again, I want to say kudos to the team. From, like, a lot of people don't realize from the initial conversations with the Deputy Mayor for Health and Human Services and the mayor's team, we were like, hey, we're going to try this thing. We don't know if CMS is going to approve it. Oh, we don't know if there's going to be a government shutdown in the middle of our application, which I think we got approved, the day before the government shutdown. There were so many things that could have gone wrong that went very well because your team worked so quickly and the partners worked so quickly and the agencies worked so well seamlessly to sort of make this happen. And there was written testimony that was shared with the committee from Dr. Candler. And they said that the transition was so seamless that some of her patients did not notice that they had a change in coverage source. They only realized it when they went to seek care at a doctor's office and they were told that the old insurance was inactive. And, your old insurance is inactive, but hey, you got this new thing, so you're good, which I think is great for residents. And that they also said that the team was incredibly responsive and made changes in the messaging. So since that initial experience, none of her patients have had issues like that. So I think the tweaks that occurred, and that was between you guys, that was also healthcare finance, is we also found that a lot of the pharmacies, they were looking in the Medicaid database, but weren't even checking the Healthy DC database, and we were able to send out some information and rectify that. How did you all modify your existing IT contracts to make sure you have this sufficient infrastructure to implement Healthy DC?
So our principal vendor for IT is DC-based CBE, actually, Idea Crew. And the way we work with them is we develop a roadmap that's actually usually 3 years old or 3 years out, I should say. And then we continue to modify it. And when federal laws change, we need to implement those and prioritize those. In this case, with Healthy DC Plan, as soon as it became apparent that we were on track to establish this new, very important coverage program, we prioritized all of our IT work to get it done. And our other vendor that actually does the premium side of things, called NFP, they do the premium aggregation for us on our small business side. We were able to utilize them to also do the premium side or the payment side, the payments we make to healthy DC plan carriers. We were able to utilize NFP to help us build that out and do that.
Okay. We heard some testimony from advocates concerned that shifting from this first year of continuous enrollment to the standard special enrollment periods would create additional barriers for those whose incomes fluctuate around the 200% FPL level. Would there be any circumstances in which the special enrollment period could be extended?
So the way we approach special enrollment periods, and as you know, we have many different types of qualifying life events where a person moving into DC or a change in circumstance can enroll outside of the open enrollment. So we monitor cases, and based on data, meaning based on cases, we determine if there's a need for a special enrollment period to address a problem that residents have in accessing coverage. And if at the staff level, we determine there's a need based on data, we work with our stakeholders and ultimately take that decision to our standing advisory board for their input and recommendation. If our standing advisory board recommends a new type of special enrollment period, then that goes to our executive board for adoption. And to date, they've adopted the recommended approach that the standing advisory board has taken with all of our SEPs, special enrollment periods. So we're going to monitor closely what happens this year. And we assume it's not really a reflection of what's going to happen next year just because of all of the turmoil and changes, just huge changes. But we will monitor this closely. And if we have an evidence-based case to make that we need a different type of special enrollment period to help address a real problem, we will take action.
Okay. There was, so when we initially set up Healthy DC, we did a automatic transfer, right? So you all received a list from healthcare finance and we automatically moved some folks over. What people may not remember is that we didn't do automatic enrollment, but we did have a warm handoff, if you will, when we started doing Medicaid redeterminations. And if somebody was determined post the public health, the pandemic and the public health emergency, if someone was determined to no longer be eligible for Medicaid, there was sort of a warm handoff to, but you might be eligible here. Have you all discussed with healthcare finance after this year what the process is going to be? So let's say they have a change in economic circumstances, et cetera, and they're no longer eligible for DC Medicaid. It won't be automatic anymore, but will there be a warm handoff or how will that work?
Yeah, so it is automatic. It's the way our,
no, but it's automatic now. I'm saying like in the future, or will there always be this automatic?
Yep. So what was different in our implementation was we didn't do one by one enrollments. We took like thousands of, in a file and automatically enrolled thousands at a time once we ran those cases through our eligibility. That's different. The way it typically works, whether you come in through Medicaid or DC HealthLink, you put in your income and other household information. And if you come to us and it looks like you're Medicaid eligible, it's not a warm handoff. It's an automatic system to system connection.
Okay.
And so that is how it works also on the Medicaid side. If you come in through District Direct, you think you're eligible for Medicaid, but it looks like, no, you're actually eligible for a healthy DC plan, or maybe the health insurance tax credit through our DC Health Link commercial side. It's all, our systems talk to each other, and so it's just automatic that we get your information. So it's not even give us a list. It's you're in our system. It determines whether or not you're eligible for a healthy DC plan, and then you'll get your eligibility from us.
Okay. So right now we have, I believe, 3 carriers who are part of Healthy DC. In the future, will you all open it up so other carriers, if they're interested, could apply?
Federal law requires 2. We're thrilled we have 3. Our population is about 16,000.
Might not be enough for a 4th.
Yeah, just in terms of entering a new market with a new, block of business for a carrier. I'm not optimistic that we'll have lots of carriers who want to come in, but our approach is always, if you want to come in, meet the basic requirements that we've established, there's now going to be a barrier to entry. It's just the population, this block is relatively small. So no one is knocking on our door yet. Okay. No one knew.
You all were going to be hiring an FTE to assist DSB in implementing Healthy DC plan. What's the status of that?
Yeah, I believe it's an MOU to fund an FTE for them to do more. Just to recollect your memory, with like the Medicaid MCOs, Deputy Turnage and Deputy Mayor Turnage and his team had a very holistic view of oversight and making sure enrollees got the care that they needed at the right time in the right setting. And so his team did all of that. With Healthy DC Plan, this is a whole new product, if you will, for us and for DSB. And in discussing this with Commissioner Woods, how do we, together with DSB, make sure that there's appropriate level of regulatory oversight? It became apparent that they would need to add an additional staff person. And so that's the genesis of us funding an additional staff person that they need. So we jointly take all the right steps to ensure there's the right kind of regulatory oversight and accountability.
Okay. Has HBX received any complaints or appeals regarding Healthy DC at this point?
Well, we have tons of cases. We have probably close to 700 cases. 75% are resolved. Most I would not call complaints. People just need help or need residents need to verify. Like half of our cases are just verifications. Yes, you are covered.
Okay.
So I wouldn't necessarily call them complaints.
Yeah.
In terms of appeals, I believe we've had a few. I will have to follow up with you on just to reconfirm that.
Okay. You mentioned in your testimony that federal law changes which restrict access to lawfully present residents result in about 126 people who no longer qualify for the lower or no cost coverage. What discussions have you had with the Deputy Mayor for Health and Human Services to try to mitigate the loss of coverage for those individuals?
So these are new customers who otherwise would be covered, but there's no federal funding. So I've made Deputy Mayor Turnage aware of this issue, and I've started conversations with the 3 carriers, the 3 health plans, to see if there's something that collectively we can do.
Okay. We've been joined by Councilmember Zachary Parker, Ward 5, who's a member of this committee. Councilmember Parker.
Awesome, thank you, and it's good to see you again. I'm really excited to say that the PrEP DC Amendment Act of 2025 has now at least received first vote. I was proud to introduce this bill. I was thankful that Councilmember Henderson marked it up. When can we expect to see implementation of preventative care for HIV with the health insurance carriers now that it's passed? And I know it's a second vote, but we anticipate it will pass.
The legislation affects the entire market, so not just health insurance through DC Health Link, but also large group market as well. So the jurisdiction, the oversight, the implementation is with DSB, and we work very closely with DSB on any changes in local law. Now, with respect to PrEP specifically, PrEP is required to be covered as a preventive benefit under federal preventive benefits structure. And in the fall, and again, this was DSB's action, and we appreciate Commissioner Woods taking it. She issued a bulletin clarifying that all preventive services that are listed federally as of December of prior year must be covered by health plans in DC. So she clarified that even if federally certain things change, our DC plans, whether through DC Health Link or outside of us, must continue to cover those services, including PrEP.
Understood. And so what I'm hearing you say is, given that memo, the coverage will be included in future health plans.
PrEP is currently required to be covered.
I know that, but let's say the federal government has its way, they continue to chip away at the Affordable Care Act or Obamacare. Part of the reason we introduced the legislation was to enshrine in local law the protections. And so if there was something that happened at the federal level, would that memo suffice, or the memo plus the legislation would ensure there is continuity and coverage locally?
I would really defer to Commissioner Woods, but my understanding is that these benefits must continue to be covered.
Understood. In your responses, you note that DC Health Link has $5 cost sharing for pediatric mental health, which is great. Does this include in-person and telehealth visits?
Yes, that's in our essential plans. So you have to be in one of our essential plans to get that benefit. And that does include specialists, group visits, essentially whatever your kid needs on mental health services.
But for those members of that essential health plan, that would cover in-person and
Correct.
telehealth visits?
Yes, as long as the telehealth visit is part of the benefit structure.
Understood. And then in the Healthy DC plan, it looks like there are some differences in how behavioral health services are rolled out. Can you explain what it looks like for enrollees trying to access these services?
Sure. So Healthy DC plan is the exact same benefit design as DC Health Link. What you're, Councilmember Parker, what you're noting is when a resident is covered under Medicaid, there are services that Medicaid covers that are not covered on the commercial side. So in this case, certain behavioral health services that Medicaid covers are not covered under ACA commercial, like in this case, Healthy DC plan. So there's a subset of behavioral health benefits that fall into that category that used to be covered by Medicaid when a person was in Medicaid, but those residents no longer have in Healthy DC plan because it's our commercial plan design, and commercial plans don't cover those benefits. We work very closely with both DHCF and we've worked on this issue with Behavioral Health Department to help identify folks who need certain services not covered by Healthy DC plan.
Understood. And I recognize some of these questions may have already been asked, but have enrollees received their medical ID cards for the Healthy DC plan?
So our enrollment is continuous. It takes up to 2 weeks to get the card. Some of our plans have online cards available quicker. All of our plans are, the 3 plans are very quick. As soon as they get an enrollment from us, in most cases, the next day, you're in their system.
And
So there's-
without the card, is the identification number required if a enrollee goes for medical care? In other words, can they access that number at least to be able to receive treatment in that 2-week window of sorts?
Yeah, the 2-week is the outer limit, by the way. Most of the time, it's much quicker to that the plans send out the new medical ID information even without the card. But yes, an enrollee can call the health plan and get their ID card
Understood.
if they need medical access to medical care before getting their ID information in the mail.
You note in your testimony that the federal government pays for 95% of coverage, but that implementation, operational, and administrative costs are not federally funded. So we're taking care of that locally, is my understanding. Is that right?
We're not locally funded. We are funded through an assessment on health carriers. So essentially, our assessment that pays for HBX operations is funding all of the staff, IT, program implementation and oversight.
The non-federally funded portion, how much is it costing the agency to run the Healthy DC plan?
Thank you for your question. So we've designed, the 95% is 95% of the value that a resident would have had if that resident had a federal health insurance tax credit. The way we've designed Healthy DC plan is to require essentially Medicaid negotiated reimbursement rates, not commercial. So the big difference is commercial reimbursement is a lot higher for the same doctor's visit, for example, compared to Medicaid. And by requiring the Medicaid negotiated rates, we're able to use that 95% to cover the entire cost of the benefits without any kind of monthly payments by residents, like premiums or any kind of cost
So
sharing.
you're getting the retail value.
So we're benefiting from the Medicaid
Yes,
negotiated rates, yes, to make the cost work. So there is nothing in addition to what the federal government pays for.
Okay, and then last question here. Are we able to add additional services to the Healthy DC plan? Understanding that it would come with an additional cost, but is that possible midstream to add services?
So into our contracts, we built in an automatic trigger for dental and vision if the federal health insurance tax credit is extended. It expired in December, so there's no additional
So
payment.
if locally we were to say we find these services to be important and we're going to pay for it, would we be able to?
We would trigger those services under the current agreement.
But only for dental and vision?
Correct. It is very difficult to add additional services mid-plan year. So if you decide additional services for Healthy DC plan in certain areas are necessary, we would work very hard to add them for the next plan year, which would start January 1.
Understood. Okay, thank you. Thank you, and Chairperson Anderson.
Councilmember Parker, we are wrapping up. So if you have any further questions for Ms. Kaufman, now's the time to.
I think I got to all of my questions. The big one, the big one was for the PrEP DC Amendment Act, but I hear you loud and clear. DISB is more so handling that. But if something were to happen to the Affordable Care Act tomorrow, hypothetically, it is your view that the plans there will still be a continuity of service.
That's correct. And if I can just add one other area. Last year, you asked me about changes in our benefits, in our essential plans for HIV to remove the cost barriers. And so just as a reminder, starting this January for this plan year, our no cost for HIV for many benefits took effect in our essential plans. So visits to your family doctor or internal medicine doctor, no out of pocket. So you're not paying cost sharing anymore or deductibles. Generic prescription drugs, labs for HIV patients are all no cost. And that is part of our effort to remove cost barriers to populations with chronic conditions. So I just wanted to make sure to remind everyone that new benefit is now in effect.
I said it last year and I'll say it again. That is a big deal. And thank you for your leadership in that space. I think that's really important, especially for those that will benefit from it. Thank you.
Awesome. All right, Director Kaufman, is there anything we haven't asked you today that you want to put on the record?
Just to say what an incredible team I have and how they've worked day and night to implement Healthy DC plan and also to make sure that all of the coverage programs we're responsible for work well for our DC employers and residents. So just wanted to thank them for all of their incredible work and also thank all of our sister agencies and stakeholders we work with. As I always say, it takes a village working with you and your team at the council, as well as Mayor Bowser and her team and all of our sister agencies. All of the success is really a reflection of our collaboration and strong partnerships. So thank you for your support as well.
And thank you all for your work and the creativity of your team on coming up with solutions on some of the issues. I know for those of the public, like we don't always send out a press release or a video or anytime we're having conversations, but the last few months, there have been constant communication. Our office, executive, all of the agencies in the health cluster as we've moved along on this process, on this issue and a lot of others. And it's tough, but it feels good when we have the win. So I want to thank you, Director. I also want to thank the public witnesses who presented their testimony. I will remind the public, if you were not able to submit or if you're not able to testify today, you still have the opportunity to submit your written testimony until March 18th at 5:30. You can do so on the council's hearing management system site, dccouncil.gov/hearings. My team wants me to note that this is the final Committee on Health Performance Oversight hearing for fiscal year 2025. Sort of. I'm gonna put an asterisk on that because we did also get the Board of Funeral Directors added to our committee. And so we'll talk to the Board of Funeral Directors in a couple of weeks as on their performance as well as on some legislation that they have pending. Yeah, we're doing before life all the way to end of life and the beyond for the Committee on Health right now. Anyway, the next Committee on Health hearing will be on Monday, March 9th at 3 p.m. We'll be marking up two bills and a nominee. We'll be marking up Bill 26-226, the Place-Based Substance Use Disorder Outreach Amendment Act of 2025. We'll also be marking up Bill 26-462, the 988 Lifeline Support and Sustainability Establishment Amendment Act of 2025. And then the Health Benefit Exchange Authority Executive Board confirmation for a Leeton Q. So the committee will meet next week and take those up. The time is now 12:47 p.m. and this hearing is adjourned. Thank you.